Hello. Yeah, Sonal.
Yes, ma'am.
Am I audible?
Yes, you're audible, ma'am.
Voice is clear, na?
Yes, ma'am, it's clear.
Okay. Thank you. Thank you.
Yes, welcome. Ma'am.
Okay. Hi, Shubham. I can see you now. Hi, Dr. Matangi.
जी डॉक्टर चारू हाय
Hi. Hi. Rashmi. Rashmi. Dr. Rashmi. Dr. Rashmi. She needs to adjust her camera.
कैमरा
Dr. Rashmi.
अभी आ जाए कॉल करके बोल दो
हाँ, yeah.
कॉल करके बोल दो
Okay, मैं बोलती हूँ.
हाय मैम डॉक्टर माथंगी हाय मैम हाउ आर यू
हाँ शुभम मैं बस लॉग इन ही कर रहा हूँ काफी देर से
मतलब कहीं अटक रहे हो
यार वो बहुत स्लो करता है ये जो खुलने के बाद है ना 7-8 मिनट हो गए मेरे को
आपका इंटरनेट स्लो है सर
नहीं नहीं
हाय डॉक्टर गोपाल हाय डॉक्टर माथंगी
Dr. Shivam, how are you all?
आई एम वेल मैडम हाउ आर यू
I'm fine. I'm fine. Hope my audio is clear.
इट्स वेरी क्लियर मैडम इट्स वेरी क्लियर
Thank you.
वंडरफुल
Now I just need to set up the screen. I'll just go out and put the. Hi, Dr. Charu. How are you?
I'm good. How are you?
I'm fine. I'm fine. Nice seeing you all.
Yeah. So you can choose the virtual background and then you can have this Nalsicon background.
Yeah, I'll just put down the video. I'll just set it
या
up.
या श्योर नो प्रॉब्लम नो हरीज
Thank you. Thanks.
डॉक्टर गोपाल हाय जस्ट चेक योर ऑडियो ना हाय डॉक्टर गोपाल
Hi Shubham.
perfect audio
Yeah.
very
Okay.
nice okay great तो आपके लिए मैंने स्लाइड्स में कुछ रखा है मजेदार
कुछ मजेदार क्या क्या रखा है बता दे
आपको बस बोलना है हाँ कीमो नहीं हो
हाँ
कीमो नहीं हो सकती
बदमाशी तो करेगा ना वो तो मुझे पता है मैं ढूंढ निकालूंगा कहीं ना कहीं फिर भी की वो।
तो सब आपको बस है, हाँ नहीं हो सकता, सब बढ़िया है, सब बढ़िया टाइप है आपका। ठीक,
सब बढ़िया है, सब बढ़िया है। हाँ।
चलो ओके ओके ठीक है। आप ये
वीडियो भी आ रहा है
बैकग्राउंड,
डॉक्टर
हाँ
शुभम?
वीडियो वीडियो आ रहा है सर। आप ये बैकग्राउंड चेंज कर लो ना, आप वो अगर वर्चुअल लगा ही रहे हो तो नालसिकॉन वाला लगा लो। मैं
हाँ
भेजूं
तो वो कैसे
व्हाट्सएप
लगाऊं
पे?
लेकिन वो, हाँ बता वो लगाऊंगा कैसे ये बता।
आप फोन पर हो ना?
हाँ
फोन में ही सेटिंग्स वाला कुछ होता होगा। एक मिनट मैं फोन अभी बात करता हूँ बात। हाय सर।
यार एक मिनट।
Good evening, everyone. Am I audible?
या ऑडिबल।
Okay.
ऑडिबल ऑडिबल।
Dr. Ali Zamikan wants to say something. Please check. Welcome, Dr. Khan.
Shubham, can you reach to Dr. Suri, please?
Okay, I'll ask him to log in.
Yeah, just call him up.
Hi guys, this is Dr. Khan. Is anybody at the other end? Hello.
Hi, sir. Good evening.
Hello,
Hi,
sir.
good evening. Am I in this session? Have I got the timings right? I'm not sure what, because there's a time difference, so I'm not sure whether I've got the timings right.
I'll wait, sir. Uploading.
So your session is later in the day. Shubham, how much later is Dr. Khan's session?
So, Dr. Khan session, sir, yours is at 4:45. So it's okay if you are here now. It's
Sure. What is the time now there? I'm sorry, I don't.
It's 3:50 India Standard
3:50,
Time.
sir. 3:50.
3:50. Okay,
Yeah.
so we've still got 1 hour. So
Yeah,
that's-
yeah, yeah.
Yes.
And I think Raman Deshpande is also talking at 4:30 India time.
So
is it?
he's in hall B, sir. You'll have to go in as
Oh, I
a
see.
yeah. So what you can do is now you're in a Zoom. Your conference window will be open behind this. So without logging off, you can actually go into the Zoom through the conference window into the hall B, and you can put this audio as silent, so you can hear everything from hall B, sir.
Okay, so you
I
can
also-
actually go from.
Yeah, and I also want your feedback. How do you find the platform also? Because we are also doing this for
Yeah.
the first.
Yeah, sure. No, it's a very interesting.
Yes, yes.
I just, how do I go back to the?
No, sir. So you are actually in Zoom now. You are out of the.
So I need to
conference
go back into the
Yes.
Internet
So
Explorer.
no. So your Explorer will be open behind this. If you will minimize your Zoom screen, you will be able to see the conference portal actually.
Yeah, no, I actually
No.
switched that off. So
Oh,
let me
okay,
turn
yes.
it back on. And see
Sure,
if I
sure,
can-
sure.
So I'm back
But-
in that room.
No problem.
So if I go into Hall B, I'll be able to listen to Hall B. Is it?
Oh yes, you will.
Oh, fantastic. Oh, very good setup, Shubham. Congratulations.
Thank you, sir. We're just trying
Very
out what
impressive.
we are trying
No.
more possibilities. So today we'll be having a small quiz also, which will come at every 15 to 20 minutes. We are trying to do more and more things. So
We should have done this virtual reality. It would have been just like
No,
I'm
sir.
sitting in
No.
Delhi.
So we talked about it, sir. We talked about it, and they told us that having that headset on for more than an hour will be painful. So you could
Yes,
have
that's
just one session as the virtual reality one, sir. And we'll do that, sir.
Yeah.
Don't worry. We'll do that as a special one. I have that in mind.
It's
This is just a beginning,
amazing.
Dr. Ravir.
I'm impressed. I'm really impressed by the way your whole platform is laid out. It feels as if I'm in Delhi at the moment, walking into your hall. Only thing missing is the Delhi chaat. I can't eat the chaat here.
You will not believe, I got an offer from Marriott that we'll provide food to all your people. They were still charging 600 rupees a plate actually for the lunch, sir.
Is that correct? Oh shit.
Yes.
I'm missing that here. I'm missing the Delhi food. I'm tired of fish and chips. Fantastic.
Dr. Samir, it's going well. Yeah,
Yes, sir.
fantastic. Good
Yes,
to see
sir.
you.
Hello, sir. Good afternoon, sir.
Hello, Gopal. Good afternoon.
Hi, good afternoon. Who is that? Hi, Dr. Harit. How are you?
Yes,
sir?
yes.
So good to see you. So good to see you. Well done, sir. Congratulations.
Absolutely.
Congratulations.
Team is rocking. Yeah, they are doing very well.
I think your boy is a star. He's become an international star.
International star, yes.
He's the future. He's the future of Indian thoracic surgery. Excellent.
Absolutely,
Well done.
absolutely.
So proud of him.
You have really created, I really admire your platform, this Thoracic Gurus. It's doing so well.
Oh, son, we're just
It's
trying our
connected
best.
people across time. Yeah, absolutely. Unbelievable. And those case discussions, everything I find very interesting. Very, very interesting.
It's been a good journey, sir.
Yes.
Can't complain.
Very, very good.
Lots to learn for us as well. Every day,
Exactly.
new case, something new to learn.
Perfect.
So you have to find a way and tell us how to do a good online quiz, sir. We are still not very happy with the way we are doing it. I'm sure you would have more ways how to do it. We tried multiple platforms.
Actually, one of my colleagues in Thailand has organized a very nice multiple quiz with the ability for the audience to vote on your keypads. And
Okay.
I'll probably ask him to send you the presentation. I'll call him today.
Yes. So the
You can
point
use
is
it
that
next
if we
week.
do it with a poll, we don't get who has given the right answer, and it has to be in real time. Otherwise, you tend
No,
to.
actually, it does do that.
It does
I
do that?
attended his.
Okay.
Yeah, I attended a whole session of his.
Okay.
Well,
okay.
even the participant knew and the faculty knew who had
Okay,
given the
okay.
right answer.
That will be very interesting, sir. Actually,
Because we did give a prize to the person who got the most answers right.
Yeah, we wanted to do that. But
I'll speak to him.
Sure.
His name is Professor Tongcharan,
Okay.
and
Okay.
he's in Bangkok. Bangkok, yeah.
Okay.
I'll ask him to send you the presentation.
Yeah, sure, sir. Sure. Hi, Dr. Suri, sir. How are you, sir?
Hello.
Hi, sir. How are you?
I'm fine.
Very
So,
well, sir. Your audio is very well, sir. I can hear it very well. Thank you. Thank you for joining in, sir.
my pleasure.
Okay.
So, how are the things? How was yesterday?
Oh, yesterday was wonderful, sir. We had 400 plus attendees in 2 halls. We had a very fruitful inauguration session, sir, where we talked a lot about how, society can get into, and we had Mr. Prashant Bhushan, Sohail Seth joining in and discussing how we can tackle the menace of smoking pertinently to lung cancer, sir. So it was really a eye-opening session, and I actually realized that they're more than happy to come on board and help us. It is us as clinicians who need to seek their help, sir. So we have to go beyond what we do treating patients to actually preventing this disease. And I'm very happy that you, Dr. Khan, and even Dr. Jain are here, that, we have to get together and do something.
Hello.
Yes, sir. Yes, sir.
We can hear you, sir.
We can hear you, sir. We can hear you, sir.
Actually, in between there was a total blackout. So I thought, what I'll do is, I think we have 2-3 minutes. I'll connect to the other alternative
Sure, sir,
network.
sure.
So that in between.
Yeah. Definitely.
Shubham, can you please share the program of the day for this session?
So it's there on your, when you go to the bar in the lobby, there's this agenda which is there. So if you click on that, you will be able to see the day's agenda.
Oh, agenda. Okay, I got it. Thank you.
So most of the things are there on. So we try to just recapitulate what is there in a normal conference, including the confusion of going to which hall and how to reach there. So it's everything is there.
So case-based discussion. Oh, that's yesterday's.
Yeah, so what we could not do is to get out yesterday's agenda, and so we were able to get only the whole agenda, not the specific agenda done.
Hi, everybody.
Hi, sir, Dr. Jain. Thank you
How
for
are you
joining,
doing?
sir.
Hi, Harit.
Wonderful. Yeah.
I see you. It's very well done, Shubham.
Thank you, sir. Thank you so much, sir.
Oh.
You found your way through the maze of connecting, sir?
Yeah. Initially, there was, it was not going into that.
Okay,
so then another way, but I think it's good.
So this is how conferences are going to be for some time, and
I think probably this will be the way forward for many years, actually, not just this year or next year.
You also have to do that mid-con, sir, ISTS. You're doing that.
No, ISCTS, that mid-thoracic has been cancelled, actually.
Okay.
Yeah, because of, there were a lot of webinars going on ISCTS behalf. So they thought maybe instead of having just one-day conference and that also virtual, probably, not more residents will be interested this time, because almost for about 3 months, there was regular, thoracic surgery sessions there.
Thanks to Dr.
The webinar.
Can we have the presentation starting? I think it's about
Yes, please. Dr. Rashmi, please start.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्. A very good evening to all of you. On behalf of MICC, Max Institute of Cancer Care, a very warm welcome to all of you in this NALCON 2020 with the 10th Annual Conference of Indian Society for Study of Lung Cancer on Streamlined Live on a virtual platform. So we are going to start our session. I would like to invite Dr. Shubham Garg, Senior Consultant Surgical Oncologist from Max Hospital, Patparganj and Vaishali, to moderate a case-based discussion on operable early lung cancer. Over to you, Dr. Shubham.
Thank you, Dr. Rashmi. Thank you for that wonderful incantation. It's really nice to start with such a pleasant voice and such pleasant words. I'll just share my screen. Yes, thank you. So we have had a wonderful day, and we'll just continue with the flow that we had left it yesterday, and we'll take things forward from that. I'll just introduce our panelists. We have with us Dr. J.C. Suri, a very senior pulmonologist. He's heading the J.C. Suri Institute of Pulmonary Sciences. We have Dr. S.K. Jain. S.K. Jain, sir, is the Associate Director of Thoracic Surgery at Medanta Hospital, Gurgaon. We have Dr. J. Matangini. She is a radiation oncologist at Gleneagles Hospital. And we also have with us Dr. Gopal Sharma, who's Associate Medical Director, Associate Director of Medical Oncology at Max Hospital, Vaishali. So with this, I will start my discussion, sir, and we'll try to be quick. We'll try to save some time. I have only one case, and I have tried to include most of the facets that we need to discuss for localized lung cancer. The case is of a 68-year-old gentleman, ECOG 1, who presented with complaints of mild chest pain with no other complaints. He was a smoker with a 30-year PAC history. He's hypertensive. He had stenting done 2 years back and is presently on blood thinners, and there is prior history of tuberculosis. This was the imaging with which he presented to us. He had a 3 into 2 centimeter nodule, a spiculated nodule in the right upper lobe. I want to ask Dr. Suri, sir, as a pulmonologist, these are very often that come to you. Probably you will be requesting CTs for some of these patients. So once they come with this CT finding, what would be the next investigation that you want to order? And these are the some ones that we have enumerated. You can choose which is the next investigation that you would want to get done.
Yeah, you have already done a CT. I would, because since it is a peripheral tumor and it's small, I would prefer CT guided biopsy in this case.
Wonderful, sir. So, Dr. Jain, you would concur, or you would want to get probably a PET CT done before?
I think we need to have a CT guided biopsy to prove or disprove whether it's really a cancer before we go ahead with the PET CT. If it's some other pathology, then probably PET CT won't be required.
So, Dr.
I think
Suri,
we'll go with the CT guided biopsy, and then once the cancer is proved, then we go ahead with the other staging modalities.
Okay. So I had asked Dr. Suri at this point in time, so what other pathology you think it could be? He's a 68-year-old male, good smoking history, speculated lesion in the lung, sir.
Yeah, I think with this kind of background, the age, a very significant smoking history, and a typical, I think, CT picture when we see a lesion which is more than 15 millimeter in size with speculated margin. I think I would consider it malignant until otherwise proved.
Definitely, sir. Also, it is solid in nature. So not just the size criteria, but the nature of lesion being completely solid, speculated margins, peripherally located. Though there was a history of prior tuberculosis, would a tuberculous scar also look like this, sir? A calcified tuberculous scar, or would it be a little different than this?
No, it is highly unlikely. And if it is calcified, then it should be bone density. You know, it's not that.
Okay, so that
it should be bone density, and also then it will not be that well-rounded. You know, it will be more like a scar. You know, with the.
There should be some heterogeneity.
Yeah.
Yes, agreed, sir. And that is what is the utility of the abdominal window of the NC-CT thorax that has been done. Not just the lung window, we should have the non-contrast window as well. The screening images that you see on the left, if you can see my arrow, this is the one that we are talking about. Okay. So, but as is case in most
So
of the.
if I can suggest.
Yes, madam. Please.
So usually we prefer non-invasive investigations before we go for a biopsy. So I would prefer to go for a PET CT in case if there are many other lesions or any other accessible lesions, because this would need a CT guided biopsy. This may look, but in spite of a small lesion, we have also seen metastatic versions, though the primary may be small. It may give another lesion a possibility of an accessible biopsy, number one. Number two, it's always preferable to do non-invasive imaging, complete everything, and then go for invasive investigations like biopsy. So I would suggest to do a PET CT before going for a CT-guided biopsy.
Completely agree, madam. That is a very valid point, and that is what most of the oncologists would actually think towards. But there are actually the National Cancer Grade Thoracic Consensus Guidelines, which also approve of getting a CT guided biopsy done first and then follow it with a PET CT. Although most of the times when a patient comes to an oncologist, he's already worked up.
Yeah,
like
our mindset is more of oncology. I agree with that.
But even when this patient came to us, he already had a PET CT done, like you said, and that turned out to be, a lesion size of even lesser size, 1.8 into 2 centimeter, with no mediastinal lobe. There were no other distant metastasis. A CT-guided biopsy, as sir had suggested, was done, and it was found to be adenocarcinoma. I have not gone purposefully into the pre-op of FNAC versus biopsy because that was discussed yesterday, but we now want to move forwards into management, and that is why. So if I could summarize these are the CT-guided image, the PET CT images of the patient. Okay.
Also, there is I'm sorry to interrupt, Dr. Shubham. There is a paper that says that the PET CT guides us to go for an exact place of biopsy. That also enhances the biopsy results, a CT-guided biopsy results, because the biopsy can be targeted at a better SUV uptake area. Sometimes, this is a very well-defined nodule. Sometimes we may have an atelectatic region also. So the biopsy may be not in the exact representative positions. So there are papers which suggested that PET CT has improved the CT-guided biopsy results. So,
ma'am, that would be you are very correct. But Dr. Suri, please,
sir.
yes.
Yes, sir.
Yeah, I think this is a very controversial topic because we know that both the sensitivity and specificity of both CT and PET CT is low. Even if you find positive on PET CT or it is suggestive of malignancy, still you need a biopsy proof for that. But when you do a CT scan and you cover the CT scan up to abdomen and you don't find any mediastinal lymph nodes, and suppose if you don't find any metastasis in the adrenal and liver, then I think the role of PET CT would become very, very limited in a case like this, because it's not going to enhance something. So I would, as a clinician, would do a PET CT in a circumstance where, suppose a case like this where the mediastinal lymph nodes are very small, it comes into stage 1, stage 2 kind of a thing, because it is not going to improve survival, because as per the studies, I would only do it to, reduce futile thoracotomies, So that situation, suppose you want to consider surgery and through CT you have not found any metastasis, because PET CT is very good at finding the occult metastasis. That is its quality. And suppose your patient is a high risk, because this patient is a high risk case here. He is having congestive heart failure, background, this thing is there. So high risk case for surgery. And suppose if he has a occult metastasis, So then, a case like this, the PET CT has a role. If we are not finding any other metastasis anywhere else in the body, you can consider this, because PET CT is superior to simple CT in picking up occult metastasis.
So, Dr. Jain, would you? Yes, sir. I just wanted to bring you in. Yes, sir.
You see, the problem with the PET CT, that particularly in the Indian scenario, that PET CT would pick up infective lesions as well. Okay, so there might be, mediastinal lymph nodes which are tubercular or infective, and tuberculosis and cancer, it does appears in so many of these patients that where we have done the mediastinoscopy or the EBUS in view of the PET CT findings and with a proven CT guided lesion in the lung, and this mediastinal lymph node, they have turned out to be tuberculosis either during EBUS or post-operatively when we do the mediastinal lymph node dissection. So if we are doing PET CT beforehand, okay, we will be mixing all the lesions there. Okay, we won't know whether, I mean, now the patient will have to undergo CT guided biopsy along with the EBUS or mediastinoscopy as well. So if we have the diagnosis pre-operatively that yes, the CT guided biopsy has proved it to be malignancy, then I think the PET CT will be more easily interpreted, and then we are ruling out the other metastatic disease elsewhere as well. And PET CT to rule out the metastatic disease is much more easier, although the sensitivity and the specificity of PET CT is again in doubt, as has been mentioned.
Sir, I agree to this confusion of getting a biopsy versus a PET CT done, but I feel you agree with me that we have to get a PET CT done after getting a biopsy. I mean, we cannot move
PET
without a
has to be
biopsy,
done.
without a
I'm
PET
not
CT.
saying that whether PET CT to be done or not done. It has to be done, but it's only the timing whether we need to do it before the biopsy or after the biopsy.
I agree on that, and I think it's more to do with the availability of PET CT. It is more to do also with the costing of PET CT. So how well so I know of places like for example NHS where you cannot actually get a PET CT done without having a proof of a malignancy, which is actually the way it should be. That you should not. That reduces the indications of getting a wrong PET CT done. Yeah, you mean you don't want to get it for a non-malignant condition. So that is also the way forward. But let's move forward with this. And I want to summarize this case that we have a 68-year-old ECOG1, a patient who has been stented. He's hypertensive. He has an early lung cancer. Clinically, the CT picture-wise, the size was 3 into 2 centimeters with no mediastinal nodes. And now I want to get in Dr. Gopal, that as a medical oncologist, many times the patient walks in more to a medical oncologist than to a surgeon, and Dr. Jain would agree with me that many times the patient walks into a medical oncologist. So when this patient comes to you, sir, what do you think would be the appropriate options for this patient?
Yeah, Dr. Shubham, this patient looks early stage lung cancer. Though age is 68 years, but ECOG is 1. And if patient fit for surgery, then the surgery is the most important treatment part in early stage lung cancer. So I would like to involve you first. Though the multimodality treatment, including radiation, medical, and surgical, is a part of tumor board discussion, but I would like to refer to you first this case. Yeah.
So we have very senior Dr. S.K. Jain sir also here, sir. So the point is that what I wanted to emphasize, and Dr. Matangni is smiling, that madam, do you feel there's another option than surgery here as well?
There is always a controversy. See, this patient looks like a borderline. See, he's a ischemic heart disease patient, though he has been stented. We have to further go for pulmonary function test and a cardiac evaluation completely, and then decide. That will be the basis of further decisions whether we are still going to go for a surgery or an alternative options. I'm not going to say that, okay, I have an SBRT tool, so I have to do it. It's not like that. So obviously, first we have to rule out whether the patient is medically operable or not inoperable.
Madam, you don't need to be submissive. You can, take the flag of SBRT higher, but Dr. Jain wants to come in. Yes, sir, please.
I think this patient has to be cleared from the surgical point of view first, only if the surgeon says that this patient is not operable for any reason. And I think this patient, whether he's having CAD or hypertension or one stent, I think that's no contraindication for surgical intervention, and the surgery will definitely give the best chance of survival in this particular patient. Unless there is a very high risk and the family or the patient is definitely against the surgical option, then of course the SBRT is
So
one
if
of the
the
choice.
options are given to the
But
patient, then it can be discussed. That is
Yeah.
what.
Sure.
So Dr. Shubham, you have to say no first, then the other options open. Yeah.
so
That's the reason I said we have to do a PFT to
Yes,
for
so
Shivam
that
to
is-
understand whether he can say yes or no.
So that is what my question was, that what further information or investigations do you want it to be done to decide between the treatment management options? And like Dr. Matangni said, that we need to get a pre-operative cardiac assessment, we need to get a pulmonary function test, and I want to stroke this thing of invasive mediastinal staging, because Dr. Suri is also here and Dr. Jain is also here, although we have had a very lively discussion. So Dr. Jain, what's your view of invasive mediastinal staging for this patient?
I think, since we have the facility of EBUS available at a lot of centers there, so I think it's better for this patient to undergo EBUS if there are mediastinal lymph nodes.
So there are no
Actually
mediastinal
very
nodes. There are
small lymph nodes there on this, but I think this patient should be going in for surgery after the pre-operative workup, that whether patient is fit for the surgical intervention and lobectomy and mediastinal lymph node dissection, and then depending upon the staging.
So you don't want to
the
offer
treatment need
any
to be done.
mediastinal staging for this patient, sir? You don't want to offer any mediastinal staging?
I think the lymph nodes are very small lymph nodes there.
Agreed,
so I
sir.
think patients should undergo with the lobectomy and mediastinal lymph node dissection. And then depending upon the mediastinal lymph node status, then the further management to be done for this.
Dr. Suri, what's your take on mediastinal staging for suspicious looking nodes? Although this patient hasn't have any, but I want your take on this thing, sir, this controversy.
See, whenever I'm seeing a patient like this, I think, what is the risk of this patient having N2, N3 lymph node involvement? Now, when the tumor is central and it is bigger, then whatever may be the size of mediastinal lymph node, the risk of having mediastinal metastasis is high. But if the tumor is peripheral, like in this case, smaller, less than 2 or 3 centimeter, if it's small tumor, peripheral tumor, then and on CT scan the lymph nodes are subcentimetric, then the risk of having stage N2 or N3, this lymph nodes N2 and 3 involvement is very low. So I probably would not like to go in for any, though I love doing EBUS, but in this case, it may not be very useful. You can straightway go in for surgery and do mediastinal
I would
lymph node dissection or sampling. Both things, that would be why I choose and the reason I've given you.
Dr. Matangni, yes.
Yeah, I'm sorry to interrupt. So the thing is, we are considering a patient who is already very old, having so many comorbidities. Of course, whether we say that surgery, like very simply, that surgery may be just, authenticated treatment, it is a standard of management. But before taking such a big decision, we have to be very sure that the mediastinal staging has been done before we are taking a radical decision of going whether surgical decision has been taken on table. Because though I'm a radiation oncologist, post-operatively, if you find N2, it's going to be really difficult and it's going to be a surprise. And the comorbidity of trimodality treatment is, of course, going to be technically difficult. And additionally, being an adenocarcinoma, the incidence of lymph node staging, the microscopic metastasis may still be there, 10 to 20%. So I would suggest, if you go for first assess if the patient is really for surgical management or a radical management, to go for a mediastinal evaluation and then decide for further treatment.
Dr. Suri, sir. Dr. Suri. Yes.
Yeah, I think if you go by the guidelines given in the latest up-to-date, this is what I have mentioned to you. This is as per the up-to-date guideline in the in management of such early stage cancers, that you can actually avoid the lymph node dissection, because the lymph nodes are very small in this case, and the risk of having an N2 and N3 lymph node involvement is very low, as the tumor is peripheral and smaller.
Okay, Dr. Jain, please. Dr. Jain.
I have got one question to all the panelists.
Yes, sir.
Suppose we have done the mediastinoscopy or the EBUS and the lymph nodes are negative. How many lymph nodes are you going to sample? If out of 14 14, 15 lymph nodes which we removed during surgery, only one is positive. The chances of that lymph node getting picked up by metastanoscopy or by EBUS is practically very little. Okay,
Sir,
so we are going to
yes.
label that patient N0 disease by the invasive investigations. Okay, so idea would be that you do the lobectomy and do the metastatic lymph node staging, and if out of 15 lymph nodes which I take out, only one is positive, I think then it will be a better chance that this patient will get. Otherwise, what we are going to do, that we are doing the metastatic lymph node dissection and then do the lobectomy, and the metastatic lymph nodes are negative on the pre-operative staging. And sometimes there is a tendency that instead of doing the metastatic dissection, you do the metastatic lymph node sampling, and the sampling may not get all the lymph nodes positive.
So, sir, what you can see on your screen are the ESTS guidelines for mediastinal staging published in 2014, and we were very fortunate to have two of the authors, Dr. Raman Ramipota and Dr. Zielinski, yesterday with us, and both of them alluded to this paper, and it is very clearly written that if the lesion is less than 3 centimeter, if it is peripheral and there are no nodes visible on a PET CT, no FDG-AVID nodes or no significantly large nodes, then you can straight away go to surgery. So I think it's better to always look at evidence, and the evidence of finding a node in such a patient is less than 2%. Okay, and in that case, it does not warrant to do a mediastinal staging.
It was a borderline. It is exact 3 centimeter here. That's why I was suggesting that.
Yes, I agree. But this is, and it's good to discuss such cases than to take a unilateral decision. That is the role of MDT always, and we always respect your opinion. But at the end, the evidence counts, and this is what the evidence is there existing. So we will not go for this thing. I want to bring in Dr. Suri, sir, that we have been speaking of pulmonary function test, and we have a very nice lecture scheduled after this talk on pulmonary function test. But when such a busy PFT report comes to me, I am at loss actually. What you think should be the two things that one should look at when we are looking at resection, sir? I have 8 minutes to finish this panel, sir. So we'll just go quickly with the next 2-3 slides.
Yeah, we basically, this patient has a background of significant smoking, 30 pack year, which is quite a lot, and we have to see this patient from 2 points of view. One is the lung volumes, and the other is the airway function. So both, now the volume also can be affected in this case because it's also a case of CAD. And if he has any kind of systolic or diastolic heart failure, because I don't know what is his echo report and whether he has diastolic dysfunction, most likely he may be having, because he's hypertensive. So if he has left ventricular hypertrophy or diastolic relaxation problem, so the likelihood of him having diastolic heart failure is also there. So this is it's a combination. So where if I find a significant mixed kind of a picture of obstructive lesion as well as the restrictive lesion, then of course this becomes quite a
but the two parameters that you would look at in this report. This is a busy report for me as a surgeon. You need to tell me two parameters that I need.
The vital capacity, the FEV1, and also the MVV. So the maximum capacity we see. But when you are going for surgery, you also have to see what will be the predicted post-operative lung function here. Yes. So which if there are set criteria for that, because of lack of time, I learned if the patient does suppose is borderline on those criteria, then we may have to do exercise studies.
Sir, I'll touch on that. So for this patient, the FEV1 was 90%. With the absolute value of 1.6 liter, and the DLCO was 78. So one thing other than the pulmonary function is the diffusion capacity that also needs to be tested, other than just the respiratory function. And what sir correctly said about post-operative predicted value, this is how we calculate the predicted value. And for this patient, this was coming out to be 75% and 65%. So, Dr. Jain, you feel this patient is fit enough for a...
Definitely, he is fit enough to be operated with these values.
So this is what the algorithm, what Dr. Suri was talking about, looks like, where you look into the post-operative predicted FEV1 DLCO and find out how severe the risk stratification is for the patient for any kind of surgery. This is taken from the Chest Journal of the American Chest Society. And you can see that any FEV1, post-operative FEV1 more than 60%, DLCO more than 60% is considered to be low risk, but anything less than 30 requires a CPET or a combined pulmonary exercise, cardiopulmonary exercise testing, which actually looks into your oxygen consumption. It's a
VO2.
combined test. Yes, VO2 max. So, and this is how what the VO2 max looks like, where you actually look into your oxygen consumption during exercise, which takes care of both your cardiac as well as your pulmonary function. Sometimes there are some surrogate tests which are actually not as big as CPET, but these are the 6-minute walk test, the shuttle walk test, and stair climbing test. And I'm sure as we move forward, we'll talk about them more. What Dr. Suri also mentioned was to assess the cardiac function of this patient. So the two cardiac investigations that we usually get is 2D echo, which is the baseline investigation. Because this patient is stented, I am very sure my my anesthetist would ask for a stress echo, and that is why the echo was done, which shows this report. Now I'll go back to this slide that what Dr. Gopal said, chemotherapy is not an option. We are looking at surgery versus radiation therapy. Of the investigations that we were looking, we have decided that we are not getting an invasive mediastinal staging. We have looked at the pulmonary function test where FEV1 is 75 and DLCO is 65%, and cardiac status wise, he is still operable. So,
mention here one thing more,
sir. Yes.
That with the minimally invasive surgeries now, which are becoming more and more common with multiport VAT or uniportal VATs, the criteria of having this PFT can be further relaxed to
yes.
number of patients there. Those who may not be able to tolerate the exploratory thoracotomy, full-fledged thoracotomy, they may be able to tolerate multiport VAT or uniportal VATs, where the stress on the patient as well as on the lung is much less than thoracotomy, and the post-operative course is much more smooth on those patients.
So with this, we have come to a conclusion that the patient is medically operable as well. Okay, but now the patient's family refuses surgery and they really want to take a non-surgical option. So my question to Dr. Matangi, and these are going to be your final words, madam, because we are running short on time as always.
So this patient, though he is fit for surgery, we can give him the alternative option of stereotactic ablative body radiotherapy. I would choose, because it is situated little 5 millimeter, more than 5 millimeter from the chest wall, and it is just 3 centimeter in dimensions. I can still go for 3 fractions of treatment.
So would you be happy telling the patient that the results are as good as doing surgery for this patient? Would you tell them with the same confidence that even if you do
2-year and 3-year local controls for all our SBRT patients, reports have been showing equivalent results, 95% local control rates and 85% survival rates, almost similar to the surgical data. And for this patient with such a small tumor and a peripheral location, the complication toxicities will also be further reduced. So I would be comfortable doing this if the patient refuses, and it would be an equivalent option just because the patient refuses. But of course, I will say the present standard guideline is of course a surgery. We have to explain both the importance and of course, but if the patient refuses, they always have an option.
Okay. Dr. Jain, your last few words on the management for this patient.
You see, the standard of care for this patient, surgical approach would be a lobectomy. But now there are many reports which are coming up for the sublobar resection also, although probably it might not fit into, exactly into that criteria. It's around 3 centimeter lesion. So about, 1 centimeter, 1.5 or max 2 centimeter lesion will qualify for the sublobar resection. Wedge resection or a anatomical, sublobar resection, I presume it's a, anatomical segmentectomy. Okay, that is a possibility there. And several studies are now proposing that the overall survival in these patients is almost equivalent to the lobectomy. But still, a lot of centers, they will still go in for the lobectomy for this particular patient with.
Agreed, sir. And these are the criteria for sublobar resection that, as sir said, the lesion size has to be preferably less than 2 centimeter. You would not want to go for lesions as big as 3 centimeter for a segmentectomy, and you should always attempt a you should always attempt an anatomical segmentary. This is my last slide, and this is for Dr. Gopal, who has been patiently waiting for the resection report for this patient, sir. Very conveniently, the tumor size is 3.2 into 2.6 centimeter. There is no perineural spread. There are no nodes. We did a very good surgery. 18 nodes came out. We sampled all the required stations, the 3 mandatory as well as the hilar. So is there a role of chemotherapy?
Yeah, in this case, there is no role of chemotherapy as well as TKI. The role of adjuvant chemotherapy in non-small cell lung cancer comes after T2, N0, M0 onwards. In T2 tumor, if the tumor size is more than 4 centimeter, if poorly represent carcinoma, there is invasion and there is pleural invasion, or there is wedge resection. So these are called high risk feature. If these high risk feature are present, then adjuvant chemotherapy play definite role in T2, N0, M0 also. And
thank you, sir. Thank you.
Yeah.
I think that is what we wanted to emphasize and set the tone for the day. Thank you. I thank all my panelists for making it a very interactive session. Thank you so much.
Thank you, Shubham.
Thank you, Dr. Shubham. Thank
it was
you.
a very
Thank
interesting
you.
discussion,
you,
and we thoroughly enjoyed it.
Thank you.
Thank you. Thank you.
So it was an excellent discussion. Thank you, Dr. Shubham, Dr. Suri, Dr. Mathangi, Dr. Jain, and Dr. Gopal. Without wasting time, we move on to the next session. 2 interesting talks on workup and ERAS and pulmonary function tests for an oncologist. I would like to invite Dr. M. Kar, Professor and Head of Surgical Oncology, who would be moderating the session. Over to you, Dr. Kar.
Yeah, thank you. Thank you so much. Already you are telling that. First, I will be grateful that I am thankful to Dr. Garg and Dr. Hari that giving me a chance to moderate this section, and the 2 eminent speakers are there, Dr. Ali Jamil Khan and Dr. Sandeep Tandon. And you already told that there is early surgery and giving that fitness. Then next is the early rehabilitation of these patients, post-surgery rehabilitation. So first I will invite, that is ideal sequence for workup with ERAS, Dr. Sandeep Tandon from Mumbai. This one, Dr. Sandeep, it is up to you now. We will not waste more time. Yes.
Thank you, sir, for your kind words of introduction. Thank you, Shubham, for giving me the opportunity to talk here on this August platform over here. 1 second, is this my screen over here that is being shared? I would like to share it from here.
You can share your screen, so you have screen share rights. You can share your screen.
Yeah, please. I prefer
you
to do
share
that.
your screen.
Yeah. Okay.
Yeah, perfect.
Okay. Thank you, Shubham, for inviting me over here today. And over the next 10 minutes or so, it will be my duty to give you an idea about what is new about ERAS and what, as a pulmonologist, what do I see about it? We have seen numerous publications coming about on ERAS over the last 15 to 17 years, and there is a lot been written about it. There have been numerous guidelines which have come out for various areas of surgery, including lung surgery. The ERAS principles for thoracic surgery have been very nicely elucidated by Dr. Batchelor et al. And it has divided them into the pre, intra, and post-operative phases. Being a pulmonologist, my current responsibility in the next 10 minutes is to give you an idea about the pre-operative or the prehabilitation part of ERAS, and I shall try to convey the importance of that to you. As we obviously start off right from the beginning, one of the most important things is smoking cessation. And as we are already aware, the earlier you ask the patient to stop smoking, you find the beneficial effects come on much earlier. We are living in a country wherein COPD is a major problem. In fact, a meta-analysis by Butler et al. Showed a pooled prevalence of lung cancer in the COPD population was 2.79%, which was much higher than the general population. People with COPD are almost 6 times more likely to develop lung cancer than controls. Even the Global Burden of Disease India report has identified that chronic respiratory diseases is a big problem in our country. And COPD is probably the second leading cause of deaths and disability limited life years in our country. And we are very well aware that existence of comorbidities in lung cancer can impact not only the survival, but also the quality of life apart from the fact that it also affects the various treatment modalities that the person can be given. And Indian data has shown a COPD prevalence of almost 41.9% in lung cancer. In a Danish study, only 31% of COPD patients had been diagnosed amongst lung cancer patients, and only 33% had received guideline-appropriate treatment prior to study. Now, this is extremely interesting. If the COPD is not even diagnosed early, how will you optimize the patient? So poor lung functions and overall poor performance status can influence and avoid a potentially curative surgical resection and prevent the patient from getting good therapy. In a study of 455 patients with COPD and lung cancer, patients with severe COPD had reduced survival after 2 and 5 years as compared to non-severe COPD, with a 69% increased risk of mortality. In fact, a meta-analysis has shown of 6 studies of COPD and post-resection lung cancer that COPD was associated with an overall lower survival, prolonged mechanical ventilation, and higher rates of pneumonia. And in these patients, rehabilitation really improved the lung function recovery and also improved the post-operative complications which would follow after surgery. Another important disease which is often overlooked is interstitial lung disease. And I'm sure you would agree that IPF is associated with the high incidence of lung cancer with a relative risk of 7 to 14 compared to the general population. Almost 2 to 4% of collagen muscular disease-associated interstitial lung disease is associated with lung cancer. And a number of studies have placed the incidence of interstitial lung disease in non-squamous cell lung cancer patients from 2% to almost 4%. In some studies, the prevalence of lung cancer at the time of diagnosis of ILD has been reported as 6, 17, and 15%. So this highlights to you the importance of early recognition of interstitial lung disease in lung cancer patients. We also need to understand that interstitial lung disease patients are more likely to develop post-operative complications leading to mechanical ventilation and death. And in 50 patients with ILD and lung cancer who were operated, almost 24% had an acute exacerbation within 30 days with a high mortality. And even interstitial pneumonitis and mortality was much higher in patients with lung cancer, those who had was almost 36% mortality. Pre-existing ILD is a very poor prognostic factor for surgical outcomes in lung cancer, and they have a higher risk of ARDS and acute exacerbation of ILD. Now, these very reasons are the fact that as an oncologist, it is very important to bring in the respiratory physician early on. In fact, there are numerous studies over here which show that an involvement of a respiratory physician in the early patient management increase the probability of patients with lung cancer getting active treatment with surgery, chemotherapy, or radiotherapy. And the survival rates also were much higher in patients who saw a pulmonologist rather than those who did not. Surgical rates were also significantly lower in those who did not receive a pulmonologist involvement because the patients were not adequately optimized. Among patients with early COPD, pulmonologist management was associated with almost a 20% reduction in mortality risk. So we do understand a respiratory physician needs to be brought in early in the management so that COPD and ILD can be appropriately recognized. Apart from that, at the first patient visit itself, while the patient is being diagnosed and worked up, nutrition is a very important factor that we can take care of and identify. A very important disease, mind you, it has now been described as a disease and an ICD code has been given, is sarcopenia, of which a lot of people are really unaware. Sarcopenia is a progressive generalized loss of skeletal muscle mass, strength, and function, and with poor risk outcomes, in which there is low muscle mass and low muscle strength and low physical performance. And the important thing is it is not detected by malnutrition risk screening tools and requires much more significant further investigations. Why I'm so much harping about sarcopenia is because it is higher amongst Asian Indian subjects with type 2 diabetes. And as we are already aware that India is a diabetes capital of the world with almost 50 million suffering from type 2 diabetes. Thus, there are enough people of sarcopenic diabetes, and I'm sure that even your cancer patients would be having them. Sarcopenia also affects almost 15% of patients with stable COPD. And India is in second place for harboring the largest number of COPD patients. So with the association between COPD and cancer, I'm sure you would understand the amount of patients with COPD and sarcopenia whom you would be treating. Another factor which is important is that India is the third most obese country in the world, and sarcopenic obesity is a coexistence of sarcopenia and obesity, which again is extremely important. You will appear the patient is having a good BMI, but the fact is that he is markedly sarcopenic. and consequently, it'll affect his outcome. Now you're seeing a particular screen over here, which I'm trying to show you, is how a number of these factors are involved. Sarcopenia, lung cancer, diabetes, which can lead rise to myopathy, sarcopenia, ischemic heart disease, again high in our country, COPD high in our country, can cause sarcopenia, can cause osteoporosis. Osteoporosis again can rise to myopathy, anemia, malnutrition, interstitial lung disease, obesity, post-TB sequelae, chronic respiratory infections, all these things. And the worst part, our population is probably very deconditioned and very physically inactive. So all this is the nidus which you will see. And with cancer-related cachexia and fatigue coming in, the problem gets to be even bigger. So the first time you start, you must assess all this, which we tend to overlook as an oncologist. As far as exercise is concerned, obviously exercise is one of the important factors in rehabilitation. This is a paper which is published this month in Anesthesia and Analgesia from Beijing. And it shows here, it was a randomized controlled trial, which says that a 2-week multimodal home-based rehabilitation program improves perioperative functional capacity and improves the 6-minute walk distance by almost 60 meters in patients undergoing thoracoscopic lobectomy for lung cancer. I think it is a worth read thing, and it is something which can easily be emulated by a number of our centers, because the debate has always been whether 2 weeks is enough or whether you should have 4 weeks or 6 weeks of time for this. Coming next, there is a newer term which is described as return to intended oncological therapy. When you talk about ERAS, you also want to see whether how fast or how quick, how many of the patients after ERAS and minimally invasive surgery actually landed getting up chemotherapy. Did they get adjuvant chemotherapy or did they not get adjuvant chemotherapy? What was the percentage? And what was the duration after which, after the surgery, when they were able to actually go ahead and get chemotherapy? So these two factors again are important determinants of ERAS, and maybe again a marker of whether a patient has benefited with ERAS or not. There is a paper which has been published in Journal of Thoracic Cardiovascular Surgery, which has shown over here that enhanced recovery after surgery was associated with facilitated delivery of adjuvant chemotherapy, with a shortened interval to receive adjuvant chemotherapy and a higher rate of receiving 4 or more cycles. So my question to you is ERAS only limited to surgery? Rehabilitation is traditionally focused on surgical treatment, but should it not be introduced early at the time of diagnostic workup itself? What if the patient needs combined modalities of surgery, systemic therapy, and radiotherapy in various sequences? Chemoradiation or immunotherapy may itself cause pulmonary issues. Early lung toxicity recognition is so important because of immunotherapy and other medication as well. Multimodality, multispeciality, and multidirectional patient flows are often seen. So we must realize that ERAS or prehabilitation should not be restricted to just a preoperative area, but it is a continuum of support before, during, as well as after treatment. And I would again bring your attention to this chart, which so well illustrates that with prehabilitation and without prehabilitation, if you see, it should be extended right from diagnosis to treatment to recovery, as well as up to palliative care. And early palliative care, again, is an important part of this. So in our institution, what we do is that we have almost most of our patients at the first assessment itself by the oncologist are invariably referred to the pulmonologist as well, especially if they have symptoms which of dyspnea, or if they have suspicion that may be having other diseases. We refer, we evaluate them, we give them bronchodilators, we do the lung function test, we do the 6-minute walk test. We refer them to the physiotherapist for a prehabilitation program. This program consists of a PR class as well as an exercise schedule, which consists of aerobic exercises, muscle strengthening, and upper limb, lower limb strengthening exercises. Patients usually undergo that for 10 days to 14 days. We have a high-risk joint clinic, which is attended by the thoracic surgeons, the chest physician, as well as the anesthetists, and we sit down together and discuss patients which are borderline. We optimize them and review them again after that to see if they are now fit enough to undergo surgery. Because as you know, the surgeons would not like to leave even a single patient who is operable, whatever the risk may be. And it is our responsibility to ensure that we take those risks. So my take-home messages are that it is never too late to start prehab, but the earlier you start prehab, the better. Even 2 weeks of exercise is better than nothing at all. Do not consider ERAS isolated to pre-op, but as a continuum of the cancer patient's journey from diagnosis to palliation. please involve your pulmonologist at the beginning itself. I have the grand privilege of working in an oncology center, and I'm surrounded with oncologists all around me. And it is so heartening to see the amount of interactions that we have amongst ourselves. You just pick up the phone, you refer patients, and this has led to a lot of learning, not even for us, but even for them. We have joint clinics where we have plural JCs and so many other things. So involve your pulmonologist. It's a fruitful bilateral relationship. Utilize services of the multidisciplinary team, including physiotherapists, exercise therapists, nutritionists, and the physician. Mind you, COPD, ILD, diabetes, TB, obesity, sarcopenia, physical inactivity are to be looked for and addressed in every lung cancer patient. This is my last slide, and I would like to highlight over here my lung cancer working group. This is our thoracic disease management group. You can see over here the surgeons over here. You can see the radiation oncologists. You can see the anesthetists over here. Here are the pulmonologists, three grand people over here. We have nuclear medicine. We have a palliative care specialist. We have a radiologist, an interventional radiologist. We have the physiotherapist. We have the medical oncology. And we have a grand director who himself is the chief of thoracic surgery. So, ladies and gentlemen, thank you so much for patient hearing. I'm open to any questions now.
Thank you so much, Dr. Sandeep. This is very lucidly and very well. I know that this is a very important aspects before surgical management, and a lot can be discussed with this, but time is there. But definitely rehabilitation, like coming to the eras in surgery, you'd think that that is not only the surgeons. Surgeons are now also becoming aware about this rehabilitation. And this is definitely lung cancer treatment is a multimodal management. That's why involving the rehabilitation before, when you diagnose or first see the patient, that definitely give a better result. We'll discuss better things. Already you have taken the time. Next speaker, I will invite Dr. Ali Zamir Khan. And everyone knows that Dr. Khan, everyone knows he is a very well-known figure in India. Now he is practicing in UK. Next, we will focus on the pulmonary function test. This is very important, not for the surgeons, for everyone, like this medical oncologist also. How patient is fit to take either surgery or chemotherapy. This is a very important topic everyone should know. And that is very rightly it is given to Dr. Ali Zamir Khan. So, sir, this is Dr. Khan. This is for you. Next, we can see the fitness pulmonary function test decoding. That is the PhD for oncologist. It is up to you to speak. Welcome, Dr.
Thank you.
Yeah.
Thank you, Chairman, sir. Thank you, ladies and gentlemen. It's indeed an honor and a privilege to lecture on this important forum. I have been given the privilege of talking about pulmonary function tests, and I will try and stick only to evidence-based medicine. So everything that I talk will be from the guidelines. So the reality, the most important thing when you're considering therapy for lung cancer is to have a live patient. And that's the most important thing, no matter what you do. So it's mandatory to assess the risk, to balance risks versus benefits, and offer surgery or any therapy on the basis that benefits outweigh the risks. That's absolutely, this should be the bottom line of treatment. As surgeons and physicians, we like to be brave. We like to push the boundaries, but it is important for us to remember, all of us to remember, that the risk is actually being taken by the patient and not by the treating doctor. Hence, it is very important to follow the guidelines and very important to follow the, the recommendations of the various societies. The two papers which I'm going to refer to today are going to be the ERS, ESTS clinical guidelines for fitness for radical therapy. And I'm also going to talk about the ACCP evaluation for patients with lung cancer being considered for resection surgery. So everything that I speak today will try and relate to these two papers and will give some guidelines for our candidates, for our participants to follow treatment. The two guidelines have actually come up with a fantastic flow chart of management. And if you do not read the whole paper, if the flow chart is the only thing that you keep with you, I think the purpose of my lecture will be well served. The one important point I want to make is in both the charts, before the pulmonology evaluation comes the cardiac evaluation. And that is why when we were discussing the case in the last session, it was very important that you should not really do pulmonology evaluation first. You must do the cardiac evaluation first before you get on to evaluating a patient for treatment with lung cancer. So both the guidelines talk about cardiac evaluation followed by pulmonology evaluation. And the evidence that I will present to you is based on the Scottish Intercollegiate Guidelines Network. So I will be giving you evidence of 1, 2, 3, and 4 with a plus added to it. And the recommendations will be based. The basic pulmonary function tests that we all get involved with are a standard spirometry with FEV1 and FVC. We also look at flow volume loops to understand whether the patient has obstructive or restrictive disease. If you want additional information, you can add whole body plethysmography to look at lung capacities and lung volumes. And all of this will give you a baseline idea of how good is the function of the lung in this patient with a diagnosis of lung cancer. But before you consider any surgical treatment or oncological treatment, it is mandatory for you to perform a DLCO. That is part of the guidelines, and I'll go into that in a bit more detail. And you must actually know what is the DLCO for these patients. So what do the guidelines talk about spirometry? They clearly state that spirometry should be performed on all patients diagnosed with lung cancer. Predicted postoperative FEV1 should not be used alone to select a patient for lung cancer surgery. They've very, very clearly said this. You have to have a DLCO and a postoperative predicted DLCO. If you just look at the spirometry, a predicted postoperative FEV1 of less than 30% is a high risk for surgery. As bottom line, remember this number, less than 30% is high risk for surgery. And prediction of postoperative PFTs is recommended by the guidelines. And the level of evidence is 2. So this is quite a decent level of evidence. So please do not do any lung cancer work or treatment without looking at spirometry and basic levels of the function of the lung. What is the recommendation for DLCO and predicted postoperative DLCO? DLCO should be used regardless of spirometry. So no matter what the numbers are, you must have an additional study of DLCO. It is not acceptable medico-legally to actually treat a patient with lung cancer without a number of DLCO, because if it goes to court, you will not be able to stand up clearly in court. A predicted postoperative DLCO of less than 30% is high risk for surgery. So 30% DLCO and 30% FEV1 predicted postoperative are the 2 cutoff numbers you must remember, and you must really worry about offering them surgery or other treatment. Again, the level of evidence is pretty decent, 2++, and a level of recommendation of B. What about segment counting? Do we need to know about the segments? Yes. Residual function, the predicted postoperative residual function should be based on segment counting of the lung. So you must know the segmental anatomy. But more importantly, when you want to predict the postoperative function, you have to look only at the segments that are not obstructed, which means the segments which are participating in the respiratory function preoperatively. Those are the ones that have to be used in the calculations for postoperative prediction. A borderline, if the patient's lung function is borderline, then an image-based calculation of the residual lung function is recommended by the ESTS. And that means ventilation or perfusion scintigraphy, particularly when you're talking about pneumonectomy. No patient with pneumonectomy should actually have surgery without a ventilation or perfusion scintigraphy. Of course, if his FEV1 is more than 2 and DLCO is more than 60%, then that's different. But otherwise, anything less than that, you must have a VQ scan. A quantitative CT scan is recommended before lobectomy or pneumonectomy. And again, the level of evidence is 2+ and B. The recommendation is B. So this is how you must know the anatomy of the bronchopulmonary segments. You must remember which are the obstructed, which are the non-obstructed segments. And this is the formula for calculating the predicted post-operative values. Now, I won't go into details of this. This is all available on the net and you can work it out. So it's a pre-operative FEV1 into 1 minus proportion of the lung to be resected. Or if you're using the segments, then it's 19 minus the segments to be removed divided by 19. So this is a formula that we use all the time. If you've got obstructed areas, then you have to remove that from the calculation. So only the well-aerated areas are the ones that are used in the predicted post-operative calculation. So it is very important to calculate the pre and the post-operative FEV1 and DLCO. Okay. Ventilation perfusion, what does the evidence say? The evidence clearly states that ventilation perfusion scintigraphy is a good predictor of post-operative lung function. But you don't need to do both. Only one is enough to give you a good indication of what's happening, what's going to happen to the patient in the long term. FEV1, DLCO, and VO2 max have been included in the algorithm. And I'll talk about these in a bit more detail. If you want to do some research, quantitative CT, MRI, and SPECT scan are the new tools that are available for understanding lung function. So these are still in the research domains. So once you have done the basic lung function test, what is next? The next step that you have is exercise tests. The exercise tests are indicated in patients undergoing lung cancer whenever the FEV1 or DLCO is less than 80%. Now, this is the ESTS guideline. If you look at the ACCP guidelines, they talk of less than 60%. So it doesn't matter whichever one that you're following, just follow one guideline and stick to it. Again, the level of evidence is quite high. So you must investigate a patient further if your predicted FEV1 or DLCO is less than 80%. What is the role of shuttle walk test in this? The role of shuttle walk suggests, the literature suggests that actually shuttle walk underestimates exercise capacity and should not be used alone. It should be used in conjunction with one of the other tests, which I'm just about to talk about. So don't use just a shuttle walk to decide that your patient is fit for surgery. Stair climbing is a very, very sensitive test. Stair climbing, you have to reach a height of about 22 meters. So it depends on whatever is the level of stairs. At least 2 floors is what we do in our traditional hospitals, but 22 meters is the recommendation. It's a cost-effective tool which accurately predicts morbidity and mortality in the post-operative period. And it is better than spirometry and first-line tests. So in my clinic, I will always send the patient up and down the stairs, or I will walk with the patient up and down the stairs. And that gives me a good idea about whether this patient can undergo surgery or does he need to undergo further investigations with regards to CPET. The one thing that you have to look at stair climbing is not just the ability of the patient to climb up and down, but also the oxygen drop after the stair climbing. So the 4%, you put in the pulse oximeter, and a 4% drop is what is calculated. And if the calculation is more than a 4% drop, you're dealing with a patient who's likely to have higher morbidity and mortality and needs a formal CPET to be assessed. 6-minute walk test is actually not well supported in literature. And in fact, the guidelines say the 6-minute walk test should not be used to select patients for surgery. So a stair climbing is very good. So spirometry, a DLCO, stair climbing. And then if you're worried about any of that, then you move to the next step, and that is CPET. Where do you use CPET? Well, in CPET, what you're really calculating is the VO2 max. And 3 numbers have to be remembered. One is more than 20 ml per kg per minute, which is low risk. The second one is more than 12 ml per kg per minute, but stopping at 20, that's a moderate risk. And the third number is less than 10 ml per kg per minute. Always get worried when the number is less than 10 ml per kg per minute. This is a high-risk candidate for surgery, and you should not consider him for surgery. He will end up with serious morbidity and mortality. And then using the VO2 max, you can also calculate a predicted post-operative VO2 max. So what is the recommendation of the guidelines? They say that VO2 peak should be done on the treadmill. It's highly predictive of post-operative complications. Very important. So VO2 is a good tool to use. They say that more than 75% or more than 20 ml, a guy is fit for a pneumonectomy. If it is less than 35% or less than 10, as I said earlier, he is too high a risk. But there is not even enough evidence on VO2 and CPET in literature as to what should be the value for a lobectomy. So always try to, it's the worry is the pneumonectomy patients, whether they will tolerate pneumonectomy or not. So work these numbers depending upon whatever you've got with your patients. Of course, they talk about future trends in terms of exercise DLCO, which could be a complement to the test. What is the operative rehabilitation according to the guidelines? Smoking cessation 2 to 4 weeks before surgery, highly recommended. Level of recommendation is B. Early pre-op and post-op rehabilitation, recommended level of evidence 2+. And pre-op exercise is inversely proportional to morbidity. So very important to work these patients up towards surgery or chemotherapy or radiotherapy. Do not rush into it. The scoring systems are not well evaluated, and I don't think we need to do that. There is also talk about need for ICU in these patients, and routine admission to ICU after surgery is not indicated. Only marginal cardiopulmonary reserve or moderate to high risk should be looked for surgery. What about quality of life? Quality of life should be used as a modality of tool. Simply PFT is not a good predictor of perceived quality of life. It is the perception of symptoms which is important for quality of life post-surgery or post-chemotherapy. So a quality of life tool must be used in analyzing these patients. What about patients with cancer surgery and LVRS? You can actually do anatomical lobectomy plus LVRS in well-selected cases. And what about anatomical segmentectomy? Now, these are the guidelines 2014, but they are being updated all the time, but the last guideline was 2014. They speak about anatomical segmentectomy in a stage 1A tumor, less than 2 to 3 centimeters, with a margin of resection more than 1 centimeters. Stage 1 in a poor PFT, lung resection after prior lobectomy, a wedge resection, or a stage 1 less than 2 centimeters. So the level of recommendation is D. So we're still not enough data to actually come up to a level of recommendation of B or A. But now the data is coming through, and I think once these recommendations change, anatomical segmentectomy will become the mainstay of treatment in patients with compromised lung functions.
Sorry to interrupt, sir. We have already crossed the time limit.
Thank you
so
very much,
requesting
sir.
to finally conclude.
No, I'm very happy to stop here, sir. Thank you.
Okay, thank you, Dr. Khan.
So just an announcement. So Dr. Sarkar is also with us. He could not join because there was a connectivity error. We welcome Dr. Mrinal Sarkar, who is the Director and Head of Respiratory Medicine, Fortis Hospital. It's a pleasure to have you, sir. Over to you, Dr. Sarkar.
Okay.
Ali Zamir, you made some very important points. First of all, that the lung and the heart are very well connected. So if the heart is not okay and lung is perfect, it doesn't help. So that's a very important point. And the various steps that is needed to evaluate a patient for lung surgery, you have highlighted very nicely. So from simple spirometry to stair climbing, which doesn't require any fancy equipment. I think these are very important. And most clinics, most hospitals would have a diffusion capacity. So these would take care of most of the patients. Of course, very borderline patients are those with high risk. We need to do exercise testing and image guided evaluation like VQ scans. So very well highlighted, and equally important to you very nicely put that we need to have pre and post-op workup of the patient so that they are in best possible condition. For instance, something as simple as optimization of the COPD, which is very commonly associated. So optimize the treatment of COPD or asthma, which may be pre-existing, and the outcomes post-op may be so much different. And of course, attention to nutrition, attention to exercise tolerance by working up on rehabilitation front. Thank you so much. a wonderful lecture and highly educated.
Thank you, sir. Thank
Yeah,
you so
definitely.
much. Thank you. Thank you, Dr. Kar. Thank you, Dr. Sarkar. Thank you, Dr. Tandon. Thank you, Dr. Khan. And I would request Dr. Khan to please stay back with us because we have a very interesting next 1 hour going to be. We have with us Dr. Mistry, RC Mistry, who's the head of thoracic surgery, thoracic oncosurgery at Kokilaben Hospital. And we also have with us Dr. Arvind Kumar, who's the chairman for the Center for Chest Surgery and Lung Transplantation. And they are here as experts for an upcoming wonderful talk by none other than Dr. Diego. Dr. Diego is the world pioneer of uniportal surgery. The way he has popularized uniportal surgery, he almost, hops on from country to country. We might hop from city to city, but he hops from theater to theater and finishes. He tells me that he has finished 3 cases till now. And thank you so much, Dr. Diego, for taking time and joining with us. We as your surgical profile is, we have kept the topic to be similar to what you do. We want to hear from you how we can further reduce the invasiveness of thoracic surgery, minimal invasive thoracic surgery, so that it becomes more and more acceptable for our patients and also for our pulmonologists. I also welcome Dr. Arvind Kumar and Dr. Mistry, sir. Over to you, Dr. Diego.
So I can start?
Yes, please. You can share your screen.
Okay. Thank you, Shubham, for the invitation, and I'm glad to see a lot of friends, Ali Samir, Arvind Kumar, many others. So my lecture is going to be about how to improve how to reduce the invasiveness of the thoracic surgery approach. As we know, since Jacobus performed the first thoracoscopic case more than 100 years ago, it takes a long time until Roviaro in 1992 performed the first VATS lobectomy through several ports. And then in the year 2010, after learning with Tommy D'Amico the double port technique, I realized that everything could be done by using a single incision. So we opened a new era of minimal invasive surgery that is what's called uniportal VATS. At the beginning, we thought that this technique was only feasible for lower lobes, but very, very quick, we approached the upper lobes and we started to perform more and more challenging cases. And we saw that this technique had no limits for minimal invasive surgery. So it was very important to show the feasibility of this approach. In addition, in the last years, we have improved the technique. As you can see on the left side, we started with a bigger incision, conventional instruments. Then we have evolved in the last years to a concept of what we call advanced instrumentation. That means to use the less number of instruments and to use small incisions with a wound protector, and in some cases with robotic arm to hold the camera. So we are trying to minimize the approach and to make it easier and simple. This is what we call advanced instrumentation. That means to use the less number of instruments, because in uniportal, if you use too many instruments, probably you will interfere with the instrumentation. So I think it's very important to learn this concept of suction harmonic working in combination to use few instruments. And I think this is a very good way to do the lymph node dissection. As you can see, we move the lymph nodes in block with the suction, and then with the harmonic or any other kind of energy device, we go cut everything slowly, like this video. We just call this technique non-grasping technique. And so that means that we don't grasp the lymph nodes. And I think it's a very good way to avoid grasping the lymph nodes and having less instruments through the incision. I think it's a very interesting technique that can be also used not only for the lymph node dissection, but also for the lobectomy, for the dissection of the vessels. But how can we even improve this? I think thanks to the high volume training centers we have established in Shanghai, we can teach this technique to everyone around the world. And we have training courses in Shanghai every year, 8 courses, where the surgeons can come with us and stay in 2 weeks. because we have improved the technique a lot for complex cases, sleeves, we can do radical resections, non-intubated, subxiphoid. But I think the most important improvement in the last years has been the development of the training courses, and we are able now to teach this technique everyone. So it's not something related to a skilled surgeon, that everyone can learn Uniportal if he follows the correct steps. In 2012, we did the first Singapore Asian meeting in Hong Kong. And after this meeting, the Shanghai team contacted me to invite me to their hospital and to learn the technique. And then we started the Uniportal Valve training courses. As you can see, we have increased the number of cases in the last years up to 17,000 cases last year. So this is why it's so important to come to our course in Shanghai, because you can learn in 2 weeks all aspects of Uniportal by seeing segmentectomies, sleeves, any kind of lobectomies, and also more advanced techniques. We can show also how to do Uniportal valve lobectomies with en-bloc chest wall resection. So this is something that we can do. We can reduce the invasiveness of these procedures when the tumor is involved in the chest wall by using a single incision. Or for the Pango's tumors, we can also reduce the invasiveness of the approach by avoiding a huge thoracotomy and using the Uniportal for the lobectomy, and then doing the en-bloc first, second, and third, and fourth rib, like in this case, exposing the subclavian vessels. You can see here everything, the black plexus and everything. So this is a way to reduce the invasiveness of the procedures. Also for the sleeves, we do a running suture, and this is the best way to do it minimally invasive. If you are thinking about a sleeve resection by doing interrupted sutures, could be a really bit difficult to do it by Uniportal or by VATS. So this is why in minimal invasive, you always choose a running suture for the sleeve resections. We can also use the robotic arm just to hold the camera, and then we have more space to work. So this is one of my favorite tools when I'm doing sleeve resections, because thanks to this arm, I can control myself the camera, and I can do the sleeve alone with no assistant. So I think it's very useful, especially for the anastomotic part. Also, we can reduce the invasiveness of the approach when we have a double sleeve by using this kind of tourniquets. If we are thinking about our beginning in this, we started using clamps to clamp the main pulmonary artery. But if you think that clamping the main pulmonary artery could interfere with the instrumentation, I think this is very useful. And we can use these tourniquets. We can live inside the chest, as you can see here. So we have more space to work. I think we can do the anastomosis perfectly in expert hands, of course, by having a lot of space and being very comfortable. Also, when we are doing the carinal resections or tracheal resections, it is very important to learn the concept of using this ventilation jet. In this way, if we use ventilation jet, we can do the carinal resection by avoiding the tube through the incision. So we can perform these cases in this way. So a lot of tricks. This is the thymus flap we always put at the end of the procedure. Also, we can reduce the invasiveness trying Uniportal approach through the neck, as Marcin Zielinski is an expert, and we did together a Uniportal course in his hospital about non-intubation, and I think he really liked this approach. The use of a non-intubated technique combined with the Uniportal is another way to reduce the invasiveness of the approach, because we don't have mechanical ventilation, we don't have the tracheal tube. So I think this is something that we can reduce even more by reducing the number of medication, the mechanical ventilation. But I have to say that this should be performed only by expert surgeons. And when you are going to do non-intubated lobectomies, in my opinion, you should be very experienced surgeon before attempt non-intubated lobectomies. But when you are expert and your team is expert, you can do a very nice and very radical procedure in a similar way as with the intubated patient. For more advanced surgeons, it is also possible to perform a carinal resection and tracheal resection with no intubation. And we reported a publication in 2018 with our colleagues from India, from China, sorry, reporting more than 20 cases of non-intubated tracheal and carinal resections. But we are still searching for the best approach. Some surgeons may prefer robotics, some others will prefer conventional VATS or subxiphoid. But how to know what is the best approach? We don't know which is the best approach. I believe that uniportal is the less invasive, but if we think that maybe you can reduce even more the invasiveness by using a subxiphoid, I think it makes sense, right? Because in this space, there's no intercostal nerve. So we have a lot of experience in Shanghai, especially a couple of surgeons that they are doing as a routine with the subxiphoid uniportal approach. But I can say that this technique is a little bit limited for lymph node dissection and for selected cases. But when we go through the subxiphoid, we can see that the view we have is a little bit limited, especially for the posterior part of the lung. In some cases, we can select the subcostal approach instead of a subxiphoid. That means that we go a little bit more lateral and we don't need to resect the xiphoid process. As you can see here, the view for upper lobes and for middle lobes is quite good. But if we are thinking about a radical lymphadenectomy, is one of the limitations in my opinion. We also need special instruments, longer instruments, as you may expect. So there are some advantages. One could be that we can approach both cavities. I think it's ideal for thymectomy. So subxiphoid have some benefits, especially for the future. If you think that you can do this thymectomy by VATS, it's very difficult to approach both sides, to see both friendly nerves clearly. But through the subxiphoid, we can approach both sides very clearly, especially when you have a retractor to elevate the sternum a little bit. In this case, you can make a good exposure and a perfect thymectomy, in my opinion, better than robotics and better than VATS. Also, for bilateral surgery, I think subxiphoid is ideal because you can remove, for example, segmentectomy on the right side and segmentectomy on the left side, or lobectomy and wedge on the left side. So you can approach both sides in a single. Also, I think it's a good approach for a thymectomy, lobectomy at the same time. Like a patient with lobectomy, we do lobectomy for lung cancer, for example, and this patient has also one thymoma. So we can approach the thymus, and we can do the thymectomy in a single way with the same incision. So I think this is a perfect technique for these combined cases. But of course, the subxiphoid approach has some limitations. And one of the limitations is that if you have an obese patient, it's quite difficult to use this approach. Or for example, what is something very easy like segment 6 or segment 2, for example, in a VATS approach or robotic approach, for subxiphoid, because it's located posteriorly, is very difficult, as well as the station 7. So I think that there are some limitations, especially on the left side, that when you use subxiphoid VATS, you compress the heart a little bit. So I think that it's not suitable for left lower cases or for patients with cardiac disease. So how can we improve this? In my opinion, all of us, we are still searching for the best approach. We are all of us dreaming about these kind of approaches where you have an ambulatory process, non-intubated, a single incision, transumbilical, no scar, no anesthesia. I think this is the dream of all of thoracic surgeons. Do the less invasive approach, that you can remove the tumor and go home after 30 minutes. But this still is not possible. This is like science fiction nowadays. But remember that everything that was science fiction was a reality in the future. So what about the robotic surgery? The robotic surgeons always say that, okay, you have improved visualization, improved instrumentation, more precision, better lymph node dissection. They are right in some sense, but they still need a lot of incisions. So we cannot, I think, compare with uniportal, which is less invasive. So what about if we combine subxiphoid approach with uniportal, with robotics? Maybe together we can develop this subxiphoid approach. And this is something that we have worked in the last years, trying to develop this subxiphoid approach with the robot. Because I think in this way, as you can see here, this is how we approach the Station 7 on the right side, through the subxiphoid single port robotic technology. You can see here, this is the right left main bronchus. You cannot expose the left main bronchus so good when you are doing subxiphoid bats. But with the robot, because it's like a snake, you can go deeper. So I think this is something for the future. So we have to think about this, and this is the view for the lobectomy on the right side, which is quite good, and I think it's better than the subxiphoid bats. So I think the robotic technology, I'm thinking about the future, could be something very interesting. Subxiphoid, uniportal, open arms inside the chest, because this is the first generation, and I think that we can improve it even more for the future, because we can adopt all the benefits of the robotic instruments, eliminating the fulcrum effects of bats, having 3D view, removing, avoiding the tremor. So I think this could be very interesting for the future. However, there are some limitations still for this. This is the beginning of this, and we are working on this to do cases in humans. But I think it could be difficult also for obese patients, because subxiphoid is for both. Maybe not easy to control bleeding through the subxiphoid uniportal robot. I don't know. We have to work more on this. I think in the future could be a reality for standard cases. So in conclusion, we can say that the minimal invasive surgery for the future is promising. We are improving staplers, narrow staplers, 3D technology, maybe non-intubated with systems to control the airway. And I'm strongly supporter of the subxiphoid approach with the robotic platform. That could be a reality in the future, I'm sure. Maybe if we develop the wireless camera zoom in combination with the magnetic graspers, and this is something that we have developed in Shanghai recently, this combination could be very promising for the future, because we can reduce even more the size of the incision, and then we don't need to use more instruments through the incision. Also, we have to open the mind. Who knows if nanotechnology will play a role to remove the tumor through the bronchial tree. So my recommendation is try to think about reduced invasiveness. Less is more, don't forget. My recommendation is start always from less to more. Start with one port. If you cannot continue, do 2, 3, as many as you need. Thank you very much.
Thank you, Dr. Diego. And I have been to his Shanghai course once, and I thought that what I experienced there was extremely something which I had not seen and not imagined. We were used to doing surgery by 4 ports, and he was doing tracheal resections by 1 port, and even for doing it by 2 ports, he would say that it's 1 port more. So thank you so much, Dr. Diego. I would want to hear from Dr. Arvind Kumar sir now. Dr. Arvind Kumar runs the largest volume center in North India. And how does he feel over the past so many years? Surgery has moved from invasive to a lesser invasive, and how can we improve on a surgery further, sir, so that it becomes more and more acceptable for our patients? Dr. Arvind Kumar, sir.
Thank you, Dr. Shubham, and thank you, Diego, for that dream-like presentation. It was almost like watching the Star Wars movie a decade or 2 ago. So it was a dream stuff where you showed your progression from doing your first case to doing tracheal dissections and bi-sleeves. And I mean, what is it that you've not done? Maybe the only thing you've not done yet is lung transplant through a single portal.
Yes.
Maybe that is food for thought. So while congratulating you, you've not only been a pioneer, but you've also been a leader. You know, many times we see people pioneer new technique, but then they fade off, and it's the others who carry it. But you actually pioneered it, and you are also a leader, and you are also a teacher who's spreading it across the world and showing to people that no, it's possible. Even you can do it. That's, I think, the biggest contribution that you have. So thank you so much, and congratulations to you. Now, coming to the science part of it, yes, while we agree that multi-uniportal is a reduction in the trauma, you would also agree that the kind of difference in the invasiveness in the body that exists between the multiportal VATS and thoracotomy, that kind of a difference we have not yet been able to produce from the literature between a uniportal VATS and a multiportal VATS. While we do have papers, randomized trials showing that there is decreased pain score, there is decreased pain requirements, there are still a lot of issues which still need to be shown. Robotic is knocking on the doors, as you yourself very rightly mentioned that there are a lot of instrumentation. The biggest drawback of robotic today, of course, continues to be the cost. And as and when the cost slashes, will that actually become, because a lot of disadvantages like suturing, etc., that we have in the conventional VATS or uniportal or multiportal will disappear with the robotic. Now, side by side, another aspect which I want to highlight is the training part, that when you have such a wide gamut of procedures being presented to a trainee surgeon, sometimes it becomes very difficult for him which one to choose. And training aspect, to my mind, is also important. While agreeing that in the hands of super duper experts like you, all these procedures are very simple and very safe, as thousands of cases you've done. But the fact remains that for an average surgeon practicing in a small town, these are not simple procedures. These are complex procedures. And I would like to use this platform to warn my younger colleagues that please don't get mesmerized by the beautiful, wonderful, amazing videos you see from experts like Dr. Diego. These are complex procedures. He's devoted his lifetime to doing these procedures. And for you, them would need years and years of very hard work, training, and most important, a teamwork. One surgeon will never be able to do it. You need a team of at least 2 trained surgeons together who can do it, of course, supported by anesthetist and a proper nursing program. Certainly, patient safety is important. I would also like to use this platform to convey a very important message that when you embark on this program, there will be occasions where you would have the temptation to carry on with these procedures, compromising the oncological safety in the interest of completing the procedure. Kindly desist from doing that. Even 2 cases to learn, and then you have your full complete case done by minimal invasive. It is better, but oncological safety should always be kept on the top of the mind. Never ever compromise the oncological safety. Another challenge which is facing us, Diego, is not the minimal invasive approach, but the non-surgical approach. As you are aware, some of these cancers are now threatened to be taken over by our radiation oncology colleagues and other people. And there is a possibility that a good number of cases which actually form the bulk of our cases today, in times to come, may actually go to, I'm not saying it's happening in the next few years, but certainly there are trials happening where there is a possibility. So I congratulate you once again on leading this unique revolution in the field of reducing the number of ports and showing this new path to the world, and also showing to surgeons across the world that it's possible to learn. And I also thank Dr. Shubham Garg, Dr. Harith, and others for organizing this beautiful conference and the opportunity. Thank you.
Thank you, sir. Thank you so much. You very well elucidated the Indian scenario and how it's difficult, probably difficult for us to adapt to this thing. But and you actually touched the nerve of our next keynote, where Dr. John Conaber is going to talk about SBRT and how it's going to revolutionize the world. But before we move on to the SBRT, I want to get Dr. Rajesh Mistry in, because just like you are the top boss in North India, Dr. Mistry is the top boss in Western part of India. And I would want to say actually that we have got a submission from Tata Memorial Hospital, actually, where they have submitted a case series of 90 patients of uniportal surgery. So it's not that uniportal is not catching up, it is catching up, but teamwork is important. Having in a good institution is important. And like what you mentioned, you should have the basics behind you, you should have the training behind you, and that is what it is there to see. But I want to hear also from Dr. Mistry, what are his thoughts about how we can convince our patients not to move towards the non-invasive SBRT, but to stay with us, with we becoming less invasive rather being non-invasive. Dr. Mistry, sir, please. Dr. Mistry? So you have to unmute yourself. So you're muted right now.
Yeah. So thank you, Shubham, for the opportunity to comment on fantastic presentation by Dr. Gonzalez, which is, as usual, very progressive. And as far as minimal invasive surgery for lung is concerned, what I would say is that VATS is here to stay. And it was just natural that from 4 ports to 3 ports to now uniportal is a natural progression. And Dr. Gonzalez has been a pioneer in this. So, this is something which is going to catch on. But the fear that you asked me to discuss about whether radiation therapy will ever take over surgery, at least for many, many years, I think this is not going to happen because we don't have randomized studies. And, till we have a phase 1 randomized study which convincingly tells us that radiation therapy is going to be as good as, surgery, whether it is minimal or, open surgery, surgeons will continue to play a very important role in all limited stage operable lung cancer. About the technique, like I said, VATS is here to stay. A recent study presented last year from UK, Violet study, has shown in a randomized trial that VATS is better than open surgery. So that goes without saying now. We have randomized evidence also. But what has attracted me in VATS is also the hybrid technique where you use 5mm ports for thorax and sub-xiphoid incision to retrieve the specimen and maybe use staplers. I find that a little more appealing than uniportal because technically it becomes easier, and the 5mm scars in follow-up are very difficult to even see whether the patient has undergone surgery. So I would like Dr. Gonzalez to comment on this hybrid technique of combining 5mm VATS incisions with little 5 a small incision in the xiphoid region.
Yes, well, I agree with. Well, first of all, I want to say that thank you, Arvin, for the kind comments. Thank you also, Rajesh, for the kind comments. I totally agree with Arvin's comments that the most important is to keep always oncological procedures, keep doing a good and radical resection, and don't care about the approach. The approach is something that you learn and you can use it when you are a good surgeon. You can do it a less invasive approach. But if you are learning, it's very important to do a radical procedure and not be obsessed with reduce the invasiveness. This is something that it comes with experience. About the comment of Rajesh, I think this is another option. I think it's everything which is minimally invasive. I agree. I mean, I agree with robotics. I agree with 3 ports. I agree with 4 ports. I defend uniportal, but I'm not against the others. As long as we don't do thoracotomy, everything minimally invasive is correct, in my opinion. So this technique could be useful because we, by using small incisions, 5mm incisions, we can reduce the invasiveness of the thorax. And the sub-xiphoid approach, we can use it for instrumentation for the camera and especially to remove the specimen. So I think it's also a good combination because sometimes the pure sub-xiphoid approach, which is the approach I'm doing in selected patients, just a pure uniportal sub-xiphoid, is interesting, but it's quite difficult for beginners. I mean, we have a lot of experience with uniportal and we can do it, but even for us, the lymph node dissection is very challenging when we are using just a single incision through the sub-xiphoid. So why not combine with this incision through the thorax that are small, and I think it's a good option. So
thank you.
My opinion is that the surgeon must be comfortable with the approach. If you are comfortable, you have to decide what is better for you. What you decide, what is best for you. There are some surgeons that they are robotic surgeons and they don't know how to do VATS. So for them, I cannot say, okay, do uniportal is the best. No, because for them, uniportal maybe is difficult. And they are very good surgeons doing robotics. So they should do robotics. They are comfortable with robotics. They can do it. They can afford. It's perfect. This is my opinion.
Very
I think what the take-home message is that you should have good training. You should be comfortable what you are doing, and as is the dictum that you should not compromise on oncological outcomes, whatever it may be. And like I really liked what Dr. actually Ali Zamir Khan said, that the patient is here to live. We cannot compromise with their lives, whether it be through the procedure, whether it be through the oncological clearance that we are doing. And I want to really thank Dr. Diago for starting this conversation where we talk on how to minimize our surgical invasiveness, and we can give better outcomes so that we can challenge our non-invasive colleagues, as Dr. Arvind Kumar mentioned, our radiation colleagues, and we can stand in front of them that, you know, we will continue to give better outcomes with lesser pay. So thank you, Dr. Diago. Thank you, Dr. Arvind Kumar and Dr. Mistry. And I now hand over to Dr. Charu Garg, who will invite Dr. John Connick.
Thank you. Hope to see you soon next year in India.
Thank you.
Bye.
Yeah.
Diago.
Bye-bye.
Thank you, Dr. Shubham. And I think after listening to a great deliberation from the surgeon's point of view, it is our proud privilege to have Dr. John Connick from UK. He is a clinical oncologist at Barts Cancer Center, UK, and he specializes in all the non-surgical treatment for both lung and breast cancers. And he has got numerous publications, and he's a recipient of various prestigious awards as well. So I would like to invite Dr. John Connick for his deliberation. Over to you, Dr. John.
So, good afternoon. Hopefully you can hear me.
Good afternoon. Yes, we can hear you.
And can you see my screen as well?
Yes.
Good. So I'd like to thank the organisers for kindly inviting me to share with you. Fingers crossed you can see me as well. So I'd like to thank the organisers for kindly inviting me to give my talk this afternoon on knife versus X-knife, which really, to me, is the debate of surgery versus sabre in the modern management of early lung cancer. So you can see there St. Bartholomew's Hospital, where I'm based in central London. So, so I have no disclosures or scientific conflicts to declare. My talk today is really going to stretch from where we began, where we are now, and look at what the potential future holds when it comes to stereotactic radiotherapy in the management of early lung cancer. And then there will be time, I hope, for questions at the end. So where it all began. So I often use this image in my presentations. This is a picture from the Royal London Hospital taken in 1905, which demonstrated state-of-the-art radiotherapy equipment at that time. You can see that patients would come for their treatment. They would sit in chairs. The device you can see there was an applicator that patients would apply themselves to the site of their disease. So it really was patient-delivered and patient-centric treatment delivery. So this was used at the time for treating many different types of cancers, but also benign conditions as well. Things have moved on though. So if we then move forward to the 20th century, this was state-of-the-art at the time, lung cancer radiotherapy planning. You can see there someone's defined where the tumor is on the orthogonal film, the chest x-ray, using PET to instruct us where the primary tumor was and the lymph nodes. And you can see on the right there a linear accelerator, which at the time was considered cutting edge. So what's happened? Well, there's been the appliance of science, and in particular, we've seen the integration of microchip technology into the devices we use in everyday life, from the phone in our pocket to the radiotherapy machine in our radiotherapy bunkers within our hospitals. And that really has transformed what we can do in terms of radiotherapy delivery. So what we've seen when it comes to radiotherapy planning and delivery is our ability to really sculpt the radiation dose around the target within the patient we're treating. So we've moved from the 2D planning era into the 3D conformal and now into the IMRT and advanced delivery techniques we use today. And that's led to new machines. So this is a true beam, so one which we have in Barts Hospital, and it now includes equipment that allows us to track the patient's breathing, which allows us to understand tumour motion within the patient, and the machine can switch on and off as needed when it thinks the target is out of its reticule and that the dose is unlikely to hit it. We've also seen now the development of robotic radiosurgery again. So this is a CyberKnife which we have housed in our department in Barts, and this fuses robotics with radiotherapy and is now able to track again tumours accurately, and the machine can follow the motion of tumours within the patient's body using X-rays to take pictures of the tumour, either with the benefit of a small gold seed next to it or because the tumour is large enough to see on plain film X-rays. So with the development of this technology has brought about the advent of stereotactic radiotherapy. But what is stereotactic radiotherapy? Well, it's an extremely high geometric targeting system. So essentially, your target within the patient's body, you are able to track it with a good degree of accuracy. You're able to deliver a very high dose of radiotherapy accurately to that target. The dose drops off over a very high gradient. So the tumor dose is high, but as you move millimeters away from that target, the dose to the normal organs around the target falls and essentially means it's safe to give and hopefully reduces toxicity that the patient may experience. So where have we moved? So if we look here on this slide, on the left you can see that older radiotherapy was essentially a dose of radiotherapy prescribed to the periphery of the target, and the tumour hopefully received a homogeneous 60 gray in this example throughout. But with the advent of stereotactic radiotherapy, we use a system where we prescribe our dose to an ISIS dose that surrounds the target. So now if I prescribe 60 gray to the 80% ISA dose, you can see that the integral dose into the tumour itself is higher, 75 gray. And here you can see an example where the 60 gray is prescribed to the 60% ISA dose. So the central core of tumour is actually receiving 100 gray, which is much higher. So here you can see a graph which relates dose response in stereotactic radiotherapy in lung tumours. So you can see the local control rate on the left in percentage and the biological equivalent dose of radiotherapy. And you can see that the shoulder of the curve really is around the 100 gray mark. So when it comes to the dose fractionation we use to treat lung tumours, it really is important that our dose is 100 gray or more in terms of biological equivalent dose to ensure good local control and tumour ablation. And in terms of accuracy, I touched on this earlier. So this is the readout from our CyberKnife in Barts. And you can see in terms of the accuracy of the robot, you're looking at sub-millimeter accuracy, somewhere between 0.1 and 0.3 millimeters. But let's pause a moment and just think about the challenge of actually treating lung cancers. So when patients breathe, unfortunately, their organs move, and as a consequence, tumours within the chest cavity, often at the lower part of the lungs, can move considerably. And therefore, when you switch your machine on to treat them, you really have to be sure that the tumours within the radiotherapy beam, for the beam to actually do some good. So this video demonstrates nicely the tumour moving up and down in the patient breathing normally whilst lying on the treatment couch. And it goes without saying that when it comes to treating lung tumours, if the surgeon is able to actually visualise the patient's tumour, so by actually entering the thoracic cavity, they can see the tumour in reality, they can shape the surgery they're performing to the actual situation they see, and they can adapt their surgical procedure to the motion of the tumor in the lung and, of course, the organs around it. And unfortunately, X-ray guided radiotherapy really does struggle to do this. And so the leaps we have made in terms of treatment delivery has helped, but it still isn't up to the ability of the surgical hand and vision within the patient itself. So there are solutions. So one is to use a fiducial, a small gold seed, which can be inserted into the tumor or next to it. And you can see a demonstration of that here. And now there's useful ways of actually inserting that seed. So one of my thoracic surgical colleagues I work with in Barts is able to deliver these using a system called navigational bronchoscopy. And I'll quickly demonstrate it now.
The lung keeps branching, literally like a tree. Once the scope can only go so far, I've got to get all the way out to this periphery. And without direct guidance, it's not like the real way to get this street invasive approach. And it lets me get out to the far reaches of the lung. It lets me get to places I could never go with accuracy. We'll take out all of the GPS instrumentation, and what has been left behind is something called the extended working channel. That channel has now essentially snaked its way through the lung, parking itself right in front of the mass, ready to now have any instrument you want go down. So we kneel out into the mass, turn on suction, back and forth, agitate into the lesion. All of my instruments can slide right through their catheter. I can core things out, I can needle.
So really what this procedure and technology now allows us to do is, even in the most peripheral lung tumors we treat, we're able to biopsy them safely with a low risk of pneumothorax. And whilst the equipment's in situ, you can deliver a fiducial to allow tumor targeting for stereotactic radiotherapy. So here's a patient who's been treated. You can see the tumor with the gold seed within it, and post-treatment how it's responded. So let's look at outcomes for early stage lung cancer treated with SABR. So it's quite clear that SABR versus conventionally fractionated radiotherapy, that SABR does result in improvements in terms of 5-year overall survival. You can see on the left here studies that treated patients with conventional fractionation with varying degrees of 5-year overall survival of 10 to 15%. Whereas on the right, early studies of stereotactic radiotherapy showed 2-3-year overall survival of 66 or even higher percent. And in fact, those studies are now growing. So there's now over 35 different studies looking at SABR outcomes, which shows increasing improvements in terms of long-term survival in patients. So what are the benefits of SABR? Well, undoubtedly, it's allowed us to offer us a radical treatment option for patients who have significant comorbidities that preclude them from surgery. This paper as well by David Palmer essentially did a literature review of severe COPD, and it looked at 30-day mortality following either SABR or surgery, and it showed that the 30-day mortality was 0% in those patients with severe COPD who received SABR, with a higher rate, 10% of mortality using surgery. And this is a controversial one. So this is data from the National Lung Cancer Audit in the UK, validated using the Danish Lung Cancer Registry, which essentially shows with increasing age, patients who have lobectomy, there does seem to be a correlation with increasing age and worse performance status in terms of post-op mortality. And again, this is from the Veterans Association in the United States on the right, which again seems to suggest that the older you are, if you have surgery, the higher their risk is for 30-day mortality. So this was a study looking specifically at age by Hasbeek, published in 2010. 203 tumors were treated in patients over the age of 75 using SABR. And what was interesting that was seen in this paper is that there was minimal, if any, grade 3-4 toxicity in those patients treated, with no difference in overall survival or local control toxicity compared to an under 75-year-old cohort. So let's talk about surgery versus SABR. So there are, of course, the old arguments of, let's for instance say, well, SABR doesn't remove the nodes for non-small cell lung cancer, so how do you know that you're truly treating a T1 tumor, N0? But interestingly, from data in the US, it seems approximately 40% or over of surgeries within the US, stage 1 disease, remove no nodes either. If we look at the list of randomized controlled trials showing that surgery is superior to SABR for early stage lung cancer, unfortunately that list is bare at present. And so if we look at the existing data that we can focus upon, it really is either retrospective analyses, propensity score matched analyses, systematic meta-analyses, or population-based analyses. And if we focus on comparative effectiveness studies, there's 20 that have been pulled from the literature comparing surgery and SABR. It seems 12 found no difference for either modality, but there wasn't adjustment for baseline factors in terms of performance status and age. And 8 of those 20 studies found that surgery was superior, but again, there was an adjustment for important baseline characteristics. So it does make you feel that there's a certain apple versus pear when you look at some of these studies on comparative analyses. If we touch on the paper by Chang et al. In 2015, which did a meta-analysis of the STARS and ROSELL studies, so by aggregating the patients from both studies to a whopping 58 patients, it did seem to show that there was an improvement in overall survival for those patients receiving SABR versus surgery. But I have to say, 58 patients rather, I would certainly take the outcome of that paper with a grain of salt. So to me, there still seems to be equipoise when it comes to surgery versus SABR, and therefore there seems to be a significant unmet need to gather further randomized controlled trial evidence of surgery versus SABR in medically operable patients. And the good news is that there is evidence being built in this space. So you have the US stablemate study, the VALOR study again in the US, the post-live study that's being conducted in China looking at radical resection versus SABR in peripheral tumors. And in the UK, where I'm based, you also have the SABR-2 study as well. And in fact, my understanding is from the stablemate study that they've already recruited more patients into the study than in prior ones before. So fingers crossed, we will recruit those important patients to power these important studies. So let's touch on tomorrow's world, or perhaps is that today? So proton therapy. So there are obviously radiological benefits, radiobiological benefits to the use of protons in terms of normal tissue toxicity and the ability to spare those tissues from radiotherapy. For instance, the heart, where it's becoming clearer and clearer that irradiating the heart in lung cancer patients can have significant implications for their long-term survival. So perhaps the harnessing of proton therapy may offer benefit when we can target tumors, I would say, more accurately with protons. There's also new CyberKnife technology. So this is an image of the new CyberKnife model that's due to be rolled out, which will improve image guidance even further using X-ray technology. But of course, now there is the integration of MR technology into the linear accelerator itself. And here you can see a 1.5T wide bore MRI scanner that's been essentially housed within a linear accelerator so that you can take MR imaging of patients receiving treatment. And that tomorrow's world has now become today. So here's an image of a LINAC, an MR LINAC manufactured by Meridian. And here you can see one of my colleagues' patients, Vini Eshill, treating a central lung tumor using an MR LINAC in Oxford, with the tumor delineated and dosimetrically planned. And what this technology allows us to do is to, on a daily fraction basis, adapt for tumor shrinkage. We're able to monitor the tumor in real time using the MR that's housed within the machine so that we can actually see the tumor motion in real time. The patient can also see that tumor motion, and it actually allows them to almost step back to 1905, where their treatment delivery is patient driven. So here we can see that patient being treated, and the patient, while lying on the couch within the machine, can see the tumor within their body. They can see the tumor move as they breathe in and out, and they're told that the blue line is the target reticule for the machine to activate to actually deliver the treatment. So they can take a deep breath in, they can hold their breath with the tumor within the target, and the machine automatically switches on to deliver the radiotherapy to treat the lung tumor within them. So it truly has become an ability, almost like surgeons, to see and adapt to real time what's going on within the patient's body. So finally then, to summarize, when it comes to surgery versus SABR, I still believe that lobectomy is the standard of care for medically operated stage 1 lung cancer patients. But let's not forget that surgery is not without its potential costs. SABR is replacing conventionally fractionated radiotherapy and has excellent published outcomes, both in local control and survival. It's important that we make sure the dose is over 100 gray, because that's key to improving that local control. It's obvious that SABR has allowed us to treat patients who weren't previously fit for radical treatment. And SABR may have similar survival to surgery for medically operable stage 1 lung cancer, but I think only trials will tell whether that's the case, and therefore it's important that we continue to recruit 2 studies to answer that important question. Thank you.
Thanks a lot, Dr. John Conybeare. I think it was a very wonderful lecture, and you have taken us through the history of radiation coming up to SBRT. And in the absence of the phase 3 trials, I mean, it is imperative to have the results from these trials and see where the SBRT would stand vis-a-vis surgery. Now I would like to invite Dr. J.P. Agarwal, who is a very senior radiation oncologist from TMH Mumbai, to have his views on SBRT in India. Over to you, Dr. Jaiprakash Agarwal.
Thanks, Charu. I think it was a wonderful talk, John. Very balanced, showing the showcase of the modern technology, and which we are going to unveil in next decade. And I think, as Dr. Arvind was mentioning in his previous talk, we have come down from a 10 centimeter or 20 centimeter lesion to a 5 mm, 5 centimeter and uniportal. I think it's time that we will go to non-invasive, definitely within coming next decade. That is one. But the most important thing, this controversy will definitely die within 10 years. That's what I think. The most important, I think, from my point of view, we should be seeing how do we integrate the systemic therapy with our SBRT. I think that's going to be really a challenge which needs to be really seen. We need to integrate the immunotherapy, we need to integrate the chemotherapy, we need to integrate the targeted therapy, and that's the challenge to control this menace even in early cancer or late cancers. Thanks, Charu, for providing me this opportunity.
You're welcome, sir. And now I would like to invite Dr. Shelly Huku, who is a senior radiation oncologist at BLK and has a rich experience of treating lung cancers with SBRT. Over to you, Dr. Huku.
Thank you, Charu, and it was a wonderful presentation and a balanced presentation from John. For last 7 or 8 years, I have been participating in debates as a speaker and as a judge, where surgery versus SBRT is discussed. But today it is the first time, and I'm very happy, and all the radiation oncologists will be happy, that Professor Arvind Kumar was threatened by radiation oncologists. Dr. Mistry was threatened by radiation oncologists. And I thought the robot is being used to give benefit to the patient and to go minimally invasive. But now today I understand that the surgeons are using robo to compete with SBRT, which is a non-invasive procedure. Anyway, with the advancement of imaging, tumor tracking, radiation delivery, and radiobiology, over the last few years, radiation oncologists have become very confident in delivering a very high dose to a very small target. And if I can share with you that we in India, in Delhi, have been treating trigeminal neuralgia, where the target is 3 millimeter and we deliver 70 gray in one fraction. What else can you expect from a radiation oncologist? And the lung tumor and the target in lung tumor is much bigger than the target of trigeminal neuralgia. Anyway, the gold standard is surgery. Surgeons will never agree for SBRT because there are no randomized controlled trials, and there have been no controlled trials because surgeons have not allowed the patients to be recruited. And you see the STAR and ROSAL trial, what has happened to them. I hope the new randomized controlled trials are able to recruit patients, and in few years, we will see that if we can treat medically inoperable patients so effectively, why can't we not treat medically operable patients? So luck to the surgeons, luck to the radiation oncologists, and a wonderful presentation. Thank you.
Thank you. So very beautifully put. And I think we are going to get some answers in coming 5 to 10 years. And if I can quickly take one question, Dr. John, what is your experience of surgery in relapsed SABR cases?
So in the center where I work, the surgeons who I work with, Calvin Lau and David Waller, they're very open to considering surgery in patients if there seems to be relapse disease within the chest. There is, though, the opportunity these days with such advanced techniques to consider retreatment, I would say, with stereotactic radiotherapy, or even one of my colleagues does intrathoracic ablation using that navigational bronchoscopy technology. So he's got a study called the NAVABLATE trial, which again offers the opportunity of using radiofrequency ablation to deal with local relapse disease. So there seems to be a growing number of options, hopefully for those patients who aren't cured the first time round.
Great. Thank you. Thank you, Dr. John. And one thing what I would like to add here is that we don't really have any real contraindications to giving SBRT. I mean, the patient may be old, the lung functions may not be so good. We can still go ahead and treat them instead of not giving them any treatment at all. So thanks a lot for joining in, Dr. John and Dr. Agarwal, Dr. Huku. Thanks a lot. And we'll close this keynote lecture here. Over to Dr. Rashmi.
Thank you very much.
Thank you, Dr. John. Thank you, Dr. Agarwal, Dr. Huku, Dr. Charu, and thank you so much. I think this is a debate which will last, and the following sessions that we are going to have after 6 p.m. are the ones which are dealing with the sequelae of treatment, whether it's surgery or whether it's SBRT, but what we are going to do after surgery or SBRT, how are we going to manage the patients, and this is what our next section going to be. So Hall A is going to be a little bit more surgically bent, whereas Hall B is going to be a more radiation bent, and Dr. Charu is taking over Hall B to make it more and more radiation heavy. So with this, we invite Dr. Rajiv Kumar. Dr. Rajiv is the head of thoracic pathology at Tata Memorial Hospital, and we have two very experienced pathologists with us who will discuss with him about pathological dissection of a lung specimen. We would have loved to have a live workshop on pathological dissection, but circumstances do not allow. May I now invite Dr. Rajiv to present his talk, and Dr. Amanjeet Bal, Assistant Professor from PGI Chandigarh, and Dr. Anuj, a very senior pathologist at Max Hospital, Saket, will be the experts, and we would want to hear their comments after this talk. Dr. Rajiv, please. You can share your screen, Dr. Rajiv.
So is my screen visible? And am I
visible and you are audible? Yes, sir. Perfect, perfect. Very nice to see you.
First of all, thanks, Shubham, for including me in this interesting conference. And the topic which I'm going to discuss is about the pathological dissection of the lung specimen. So before I go to in specific to the lung, I just like to briefly touch up upon the basic fundamental of grossings that include when, as a pathologist, we receive a specimen, we would first like to have it a proper orientation, measures its dimensions, identify the lesion, and if it is the neoplastic etiology is suspected, we like to ink the surgical margins and then do the adequate sampling of the lesion as well as the adjacent normal structures, and for in order to give the comment whether the surgery is complete or not, the margin assessment is required. So why this all exercise is required, or why the meticulous grossing is required? First, it's not only to confirm the pre-operative diagnosis which is established on the biopsy, but the clinician are more interested in the parameters which decides the further course of management and the prognosis of this patient, that is about the TNM. So that's why the meticulous grossing is so much required. And in the interest of time, I'll restrict my talk to the tumorous pathology. So coming to the basic, before we start with the grossing of lung, everyone should be aware of the structural surgical anatomy of the lung, and in that I'm not going to go into detail of each and everything, but these 5 components, like as a pathologist, when he is grossing, he should be aware that airways, lung parenchyma, pleura, vessels, and the lymph nodes, because the whatever the sections or they are going to take, they are in relation to these 5 parameters. These are the various list of the various specimens which as a pathologist we come across, ranging from the pneumonectomy, in which entire lung is removed, to the segmentectomy, where only the small portion or the wedge of the lung is removed along with the lesion. So these are the various specimen types we should be aware, and as a surgeon, whenever they do the procedure, they should label it properly rather than just writing it as right lung or left lung. So when a specimen come to a pathologist, in addition to the specimen, some basic clinical or radiological information is mandatory. That includes the site of specimen and type of surgery, radiological information about the location and number of tumors, especially if there are multiple tumors, those should be conveyed to the pathologist so that he can do the meticulous search for the additional number of the lesions, lymph node status, and about the adjacent lung, if is it showing any background pathology like ILD or pneumonia like changes. In addition, if there is a patient has received a new adjuvant chemotherapy or immunotherapy, though that should also be conveyed to the pathologist, because the treatment, the way the grossing is done is different as compared to the conventional specimen. As I mentioned earlier, the radiology is one of the most important radiological features, are most of the important thing which as a pathologist, when he's doing the grossing of the lung, he should check for them, because many times, as you can see in this scan, there's a large lesion, peripheral lesion, but in addition there are some small lesions. So if the pathologist is not aware about these lesions, it helps to pick up these lesions more easily to them. And in addition, there are some circumstances in which it is difficult to identify the lesion, especially if the tumor is having a lipidic growth pattern. So in those cases also, radiology helps the pathologist a lot when you are dealing with the specimen. So first step, as I mentioned in my first slide, is the orientation of the specimen. So after you receive the specimen, try to orient it in 3 dimension, take the gross photograph of especially of the external from the external surface, as well as after the even the slicing, so that there is a record of each and every step it can be maintained, so that whenever in future if you want to correlate the findings with the radiology, it becomes quite easy in a tumor board. Next step is about the
Hi sir, hi sir, good evening. आपको
login
invite कर रहा था sir.
in thoracic, especially in the
अपना वो e-faculty lounge
of the specimen is slightly different as compared to other type of specimens. Here, the for fixation, we don't try cut open the specimen, but try to infuse the formalin through a bronchus, either using a large syringe, or it can be even injected through the pleural aspect using a syringe and the needle. And the specimen is fixed for around for overnight in a 10% neutral buffer format.
Before grossing the lung specimens, they should be distended with formalin. This can be achieved by instilling formalin via the bronchus. One can either do this using a flexible tube with a reservoir or a large volume syringe with a wide nozzle, as you see me doing it. In segmentectomy specimens, the lung is inflated by injecting formalin through the pleural surface using a needle and syringe. The specimen is distended until the pleura is smooth, and the specimen is then placed in a large volume of formalin and allowed to fix for approximately 24 hours.
So after the specimen got fixed, next is to how to dissect the lung specimen. So as I said earlier, the approach should be to expose the lesion in such a way that its orientation with the structure, the adjacent structure, especially the bronchus and pleura, is well maintained. And first step is to localize the lesion. And how do we localize the lesion? Because many times the lesion or the tumor can be very small, but the overall specimen is very large, and it's difficult to identify where the tumor is exactly located. In these cases, first check with the radiological findings, and you can even inspect the pleural surfaces. There can be some area of thickening or retraction, so the tumor must be sitting just below it. And the best thing for the lung specimen is better not to only to see it, but better to palpate the lesion. So just to give you a few of illustrations, is you can see there is a pleura which is otherwise smooth and shiny, but there is an area which shows opaque and haziness. There can be area which is puckering, and sometimes you can see the nodule. So why it is important grossly to identify these changes in the pleura? Because if you see these changes, then the likelihood of this tumor being T2 is very high. And after you confirm, you either confirm or suspect the pleural involvement, that area we have to sample and examine and confirm it by microscopy. And it is very important to understand, especially for the pleural involvement, is not important that tumor should breach the pleura and reaches the surface. So even if it breaches the internal elastic lamina of pleura, which is highlighted by elastic stain, it is considered to be involved. So if either the tumor reaches at the surface or it breaches the internal elastic lamina, both of the outcomes of both of them are same. So we have to, even if the tumor is not breaching the pleura, we have to sample that area in which the tumor is close to the pleural aspect. Next important thing which we have to see on the external surface is whether are there any additional structure which are attached to it. They can be from either on the mediastinum side, or it can be from the chest wall side. So these structure, if you see, we have to paint them, and because because in addition to commenting on whether it is invaded by the tumor or not invaded by the tumor, we have to also comment on the margin, especially if there are ribs or chest wall structures are removed along with it. Then coming to the margins, margins in the lung specimens, we sample two types, mainly predominantly two type of margins: bronchial or vascular margins, and the lung parenchymal cut margins. And if there are adjacent structures are attached, then even we have to sample for the rib or the chest wall margins. For the bronchial margins, they are usually taken as a shave margin. We just chip off the ends of the bronchus or the vessels. Whereas to assess the parenchymal cut margins, we have to remove the area which is stapled and ink it with the ink it and then take the proper section. This is some of the examples to show there is a, you can see there is an endobronchial tumor, and this surface form makes the margin, so which we have to evaluate. But there, especially while dealing with a bronchial margin, there can be some problem which as a pathologist face or encounter. So when to call the margin as a real true positive margin? First thing, if you see the tumor at the margin. Second, if there is either in situ carcinoma in the lining epithelium or invasive carcinoma which is adherent to the bronchial wall. So in those conditions, we have to label it's positive. Otherwise, there can be circumstances in which the tumor is protruding into the to bronchus, and the actual margin is free. So we have to be very careful when in such situations. So as I mentioned earlier, there are two type of margin, bronchial and parenchymal, and usually bronchial we take as a shave margin. And when evaluating this margin, we have to see that at the complete circumference of the bronchial margin should be there before we call it as a negative margin. Next step is about dissection of the tumor. So there are various methods to cut open the lung. One way is it can be opened through the airways, and another is a serial slicing. So there are advantages of each and every method, but it all depending on the where the tumor is located and what type of specimen it is. This photograph shows you just an illustration of in which the lung specimen is sliced from caudal to cranial, cranial to caudal end. So you can see there are multiple slices has been taken which are placed on a board, and after you slice each and every slice is examined very meticulously to locate for the tumor. So as we can see that tumor is present in the slices which are 9 to 12. So after you localize these slices, we have to see what is the relationship of these tumor with respect to the adjacent structure like bronchus or pleura, and do the sampling accordingly. So this is very much important to see. So, and this can be easily correlated with even the radiological extent of the tumor. So this is another example. Here we can see there is a large tumor mass, and you can see the pleural surface on the 3 side. But when we are sampling this case, we have to sample the area which is close to this particular arrow, because that the likelihood of this being showing a pleural involvement is very high. And in addition, try to look also for the adjacent nodule. There are some other examples in which the lung parenchyma is healthy but the pleura is thickened. So this is a example of mesothelioma, gross of mesothelioma, and so the sampling in these cases will be done accordingly. Now I'll just quickly cover some of the problematic areas which we face. So these are the problems which we encounter when we try to stage the disease. So I'll come one by one to it. The first one, and the first of it is about the location of tumor and what is its clinical relevance. So earlier, the location or the relationship of the tumor with respect to carina was considered very important till the 7th TNM. And so we have to, it is expected that pathologists measure the distance of the tumor from the bronchus, but many times the carina was not included in the specimen. So it is very difficult for pathologists to evaluate that. So in the 8th TNM, this the criteria was removed. So any tumor which involves the bronchus is considered to be as T2, because the pathologically assessment of the actual distance from the carina was difficult. Next is about the size of the tumor, because the size is one of the important criteria for T staging of the lung cancers. So first issue is when to measure the tumor size. Is it as we fix the? It is mandatory to fix the lung specimen before we actually can cut through it. So when to measure the size? Is it should be done in the fresh state or after fixation? So as I said, fresh. It is better to if it is ideally it should be done in the fresh state, but after fixation some shrinkage is expected, but the infusion method which I showed you as a video, which causes the least shrinkage, and it is recommended because it causes the least tumor shrinkage.
Excuse me, Dr. Rajiv, I'm sorry to interrupt you. We hardly have 1 or 2 minutes left. If you could just sum it up quickly.
Okay, because we started at 6-7.
Okay, you can please take 3-4 minutes, maybe maximum 5. That would be nice.
So another issues with the T size is because there are certain tumors like carcinoma with lipidic growth patterns. It is difficult to assess the size. And another issue with if there is a tuberculosis, or in those cases there can be overestimation of the gross size. So in those cases, microscopic assessment of the size is more relevant. This another example like adenocarcinoma in C2, which is but the invasive component is less than 5 millimeter. Another important aspect which we have to evaluate is about the tumor nodules. So if there are adjacent tumor nodules in the same lobe, it is a T3 stage, but if they are in adjacent lobe, it becomes T4. And another issue comes when you see the multiple nodules. Is it the same tumor? Is it a synchronous tumor, or the tumor intrapulmonary metastasis? So how to go about it? So if the histology of the two lesion is different, then it can be regarded as a separate tumor. But if the morphological pattern is same, then they are regarded as a same tumor. Of atelectasis, I just like to say that it is now in new TNM, it is called as a T2, whether it is a partial or complete. And finally, about the post-chemotherapy specimens, as post-chemotherapy can cause a lot of changes in the tumor as well as in the surrounding lung. There can be overestimation or underestimation of the T size. So in these cases, it is how to evaluate the exact TNM staging. So recently, the ISLC has proposed the recommendation how to gross these cases. And now it is recommended not to take only 3 to 4 sections, standard sections, but we have to embed the entire tumor bed. And in this tumor bed, the percentage of viable tumor, necrosis, and stroma is evaluated to give a actual pathological response. And if anything which is less than 10% is called as a major pathological response. And also based on this, the tumor size can be calculated easily if you multiply the viable tumor area with the tumor bed. And finally, about the lymph node, there has to be sampled, and the reporting has to be given as per the state.
Yes, sir. So I think we have lost connection.
Yeah. Hello. Yeah. Am I audible?
You're audible, Dr. Rajiv.
Yeah. So this is the final slide, which shows the summary of the changes which are there in the 8th TNM as compared to the 7th TNM. I will not go into details due to short of time. These are just some illustrations in order to remember this. So and finally, when you're done with your grossing, there is a minimum data set of the reporting which or data element should come in the report. And these there are many recommendations or data set from CAP or RCPath. There are some data set which we have developed, and it is available on National Cancer Grid website, and the link is also available in the conference portal. So you can use these data sets, especially for the thoracic tumor. And with this, I end my presentation. I have video. If I have time, then I can show. Otherwise, I have told.
I think we are short on time.
Yes, yes.
Thank you, Dr. Rajiv. You have given an excellent overview on how to approach comprehensively, how to approach a specimen with malignancy. I'm sure all the pathology delegates present here would have taken some very meaningful take-home messages from your presentation. I just have a very quick question for you. Like, what is your take about atelectasis upstaging the disease? How can a pathologist upstage a disease which is more clinical and radiological?
Yeah, so this is one of the interesting thing, and there are a lot of inter-observer variability in evaluating the atelectasis. So the best thing is to go and check with the radiology. If there is any evidence of atelectasis present on the radiology, try to sample those particular areas. And even as per new TNM 8th classification, if there is a partial or complete atelectasis, both has same implication. So it will be T2 disease rather than the T3.
Thank you, Dr. Rajiv. I'll hand over to Dr. Amanjeet Bal for giving her expert comments for the session.
Yeah, thank you. I think Rajiv has almost covered everything. He has given a broad overview in a limited time. So in the interest of time, so major two problems which we face as pathologists is assessing the size of the tumor, which has already highlighted. Fixation is one reason. And second, when the tumor margin is not very well demarcated on gross. So we tend to measure a more size. So in those cases, we have to correlate it with the microscopic sections. And second, in the setting of neoadjuvant chemotherapy, when you do not find a tumor bed. So either you look for the pleural retraction, or you palpate the pleural surfaces, or you tell your surgeon to at least help you to mark a suture at a site of tumor bed. And the second problem which we face is, the lymph nodes are dissected by the surgeon. So medius renal and hilar, they are sent by them in separate containers. So it's easy for us. But we usually overlook the intrapulmonary lymph node dissections, because they are difficult to dissect. So we have to train our residents so that they should follow a peribronchiolar path from a hilar region to a peripheral part, doing a blunt dissection and looking for intraparenchymal lymph nodes. So we have done mistakes few times, we have called it N0, but when we regrossed it, it turned out to be N1. So intrapulmonary lymph nodes, which is a responsibility of a pathologist, should not be overlooked, should be dealt with, nicely. So these are my two, points which should be taken care of by a pathologist while grossing. Thank you.
Thank you, all the experts, speakers, and a special thanks to Dr. Shubham and Dr. Charu for having this wonderful keynote lectures. So we are going to move on the next session. So for the next session, I would like to invite Dr. L.M. Darlang, Head Thoracic Oncosurgeon, Rajiv Gandhi Cancer Institute, New Delhi. Dr. Arvind Krishnamurthy, Professor Surgical Oncology, Cancer Institute, Adyar, Delhi. Dr. Anil Kapoor, Thoracic and VAT Surgeon, Meerut and JP Hospital, Noida, Delhi NCR. Over to you, sir. I request all the speakers and chairperson to please open your video.
So may I request Dr. Darlang to invite Dr. Diwan, please?
Yeah. Good evening, Dr. Shubham and all other team members. I would like to invite Dr. Diwan from NITRD, Delhi, who is the head of thoracic surgery, to be speaking on a topic that's...
I'm not able to start my video. It says I've been blocked by the host.
Okay,
So
we are trying to shorten.
We'll just rectify that, sir. You can start screen share if that is possible,
Okay.
sir.
I'll start the screen share, yes.
You are visible, sir? Now you are visible.
Okay. Yes, I'm visible, yes. Okay. So, thank you, Dr. Shubham, for inviting me for this talk. Air leak after lung resection for lung cancer. In fact, air leak after any lung resection is a perplexing problem for almost all thoracic surgeons. And most of my presentation is based on my, of course, experience, which is more in the area of tuberculosis, but I have done 100, 150 plus surgeries for lung cancer also. But generally the principles of preventing and managing them remain the same. And in addition to the gleaning of literature that I have done for this presentation. By definition, a post-operative air leak is defined by air escaping the lung parenchyma into the pleural space after any kind of surgery in the chest. About 50% of patients present with at least minor air leaks after lung resection. Majority of air leaks stop spontaneously after a few hours to up to 3 days. So when will you call it persistent air leak? It is arbitrary and generally institutionally defined between 5 to 14 days. Because most of my work is in inflammatory lung disease, we don't say it at least up to 7 days that it is a prolonged air leak. But nowadays, generally we see that with good techniques and other things, 3 days to 4 days, a normal case, which is not going to be persistent air leak does stop. Defining a persistent air leak as air leak beyond postoperative 5 is average after pulmonary lobectomy and is consistent with Society of Thoracic Surgeons database definition. Air leak exceeding the otherwise necessary length of hospital stay. So this is PAL, or prolonged air leak. What are the risk factors? Now, this was a good article. Air leaks following pulmonary resections for lung cancer. Is it patient related or surgeon related? Most of us would concede that at least at the beginning of our surgical career, number of leaks are surgeon related also till we are perfecting our technique. But of course, there are various factors intrinsic to the patient who are responsible for it. What are the preoperative factors? And in various studies which they have done from the univariate analysis, the significant factors are female sex, low body mass index, low predicted FEV1 or post-operative predicted FEV1. It is quite significant. Chronic obstructive pulmonary disease, which is present in many patients, especially 50 years plus, or those who are on inhalers. And if there's a higher pack year history of smoking. These are all significant factors which increase the chances of patient developing post-operative air leak. Only low post-operative FE1 is the most important factor as far as multivariate analysis has confirmed. Other factors are being shown only in a single study. Intraoperative factors. What are the significant factors on univariate analysis? Lobectomy more than a sublobar resection. Resection of the upper lobe is more commonly associated, and malignant disease. Of course, we are talking in the context of malignant disease. Multivariate analysis, lobectomy, and resection of the upper lobe. These have been found to be the most significant intraoperative factors. Other risk factors, like other diseases, coexistence of emphysema or underlying lung disease, or chronic inflammation like tuberculosis, aspergilloma. As such, if you are doing surgery for tuberculosis, aspergilloma, most of the literature has shown that the incidence of bronchopleural fistula formation is higher there. But that's slightly different condition. But as far as air leak, TB per se causes the lungs to be diseased, and some areas may increase the propensity for development of air leak. Cystic fibrosis also. Prediction by scoring systems. Now a scoring system has been proposed by these authors from Spain to predict the risk of postoperative air leak after lobectomy. Of course, these are mostly on patients with lung cancer, and in which they have assigned points. If age is higher than 65 years, they have assigned a point of 1. BMI is less than 25.5, then a point assigned is 2. FEV1 less than 80%, 1.5, and presence of pleural adhesions at operation, 0.1. And then they kind of did a study in which they have distributed patients and incidence of this air leak in derivation and validation sets. And they have divided to class A, class B, class C, class D. It is intrinsic to this particular study. I'm skipping it. But the conclusions they developed that developed scoring system reliably predicts incremental risk factors for pulmonary air leak after pulmonary lobectomy. Estimating the risk of prolonged air leak after pulmonary resection using a simple scoring system. From August 2002 to March 2007, 587 patients underwent resection in this study. and scoring system with the total number of points indicating the probability consisting of pleural adhesions 2 points, FEV1 1 point per 10% below 100%, and DLCO 1 point per 20% below 100%. Grading of air leaks was done that grade 0, no air leak, grade 1 is countable bubbles, grade 2 is stream of bubbles, and grade 3 is coalesced bubbles. Qualitatively, what are the types? Active air leak is said to be present when there is appearance of bubbles at same intensity at repeated coughs. While it is called passive when intensity is reduced with each cough and maybe stops after a few coughings. The grades have also been defined as continuous bubbling, inspiratory bubbling, expiratory, or forced expiratory. And this is the common pleurovac system which is used very often, which measures the leak on a scale from 1 to 7. And that is how it works. If the air leak is more, then surgeons are more concerned. And this digital system, which we have found quite useful in our practice because it accurately tells you how much air leak is taking place, and it is also a great guide to be able to remove the chest tube when it becomes 0 or less than 40, some people say, but I will prefer that when it becomes 0 and at least for 24 hours it remains 0, then the chest tube can be safely removed. Digital portable chest drainage suction systems are a significant advance in the practice of thoracic surgery and the care of these patients. What are the consequences of air leaks? I think most of the surgeons wrestle with this problem day in and day out. Prolonged chest tube drainage causes prolonged pain. Restricted ventilation leads to increased risk of pneumonia. Decreased mobility through chest tubes and related pain. Decreased mobility results in increased risk of thromboembolism, especially in older patients. It necessitates pleurodesis, sometimes mechanical ventilation, and reoperation. Higher readmission rate to intensive care units, prolonged hospital stay, and related higher overall costs. In fact, prolonged air leak and whatever are the resultant issues and complications which result from it are a reason that all thoracic surgical patients in their consent should be informed that there is a possibility and they should increase their hospital stay. What is the management? If there is a bronchopleural fistula from any reason, and bronchopleural fistula actually is a topic itself, and I have tried not to cover in this particular presentation, while if there is peripheral lesion in the viscera pleural, then the management differs. BPF is a separate topic. So generally, we are concerned about air leak if it is a surface air leak. BPF is not being considered in this talk, but persistent air leak, what are the management options? Most often, in majority of the cases, the conservative approaches are good enough, which include prolonged chest tube drainage, and after 2 weeks, provocative chest tube clamping or permissive chest tube removal. Permissive chest tube removal, you see that even if there is an air leak, you still remove the chest tube after 2 weeks and find that nothing happens. The lung doesn't collapse and patient can be safely managed. Good physiotherapy, of course, is mandatory. Outpatient management with a chest tube and Heimlich valve, because unnecessarily you cannot keep a patient admitted just because the air leak is taking place. And with a Heimlich valve, patient can be discharged and patient can come back after 1 week or 2 weeks. These approaches work quite well in majority of our cases in the practice of most of the thoracic surgeons. But there are other options in cases resistant to these approaches. Pneumoperitoneum is one. Then pleurodesis using either tetracycline, talcum, silver nitrate, autologous blood patch through the chest tube. Then nowadays with interventional bronchoscope is being very active, and intrabronchial valves have been developed, which will close the particular bronchial opening from where air leak is taking place, and one can stop it. And then there are surgical options, which will be considered quite late. Early surgical options like sclerosing agents, pleural abrasions or pleurectomy, and late surgical options like muscle or omental flaps. I have not included other options like thoracoplasty, etc., because they are generally reserved for bronchopleural fistula, and that is causing persistent air leak and persistent space in the pleural cavity, which is a situation which is unlikely to develop after cancer surgery. About suction, it is a controversial topic. Alfonso et al. They found no routine application of suction unless clinically indicated. And another study in randomized controlled trial showed no statistically significant difference between groups when they're concerning duration of air leak and number of cases of persistent air leak by the use of suction. While Serfolio study shows that he's highly favoring the water seal group, that is without suction, while Marshall favors another data for non-suction protocol. Conclusion: evidence is that an initial short period of suction followed by water seal drainage is safe and can reduce air leak on chest tube duration in the absence of relevant pneumothorax, progressive subcutaneous emphysema, or cardiorespiratory deterioration. But water seal only protocol, a chest X-ray is mandatory after switching to water seal to detect a relevant pneumothorax, which is an indication for applying suction of at least minus 10 centimeter of water. In our practice, we've seen that suction, especially the digital portable chest drainage suction, definitely helps in reducing postoperative air leak because it keeps the lung expanded. And once the lung is expanded, surface air leaks tend to stick to the chest wall. Of course, we don't have a study to corroborate it. It's a general experience. In conclusion, a water seal protocol might not be advisable or even contraindicated in patients with highly restrictive lung disease and those in whom there is a subsequent risk of bleeding also, because surface oozing also stops if you keep the chest drainage tubes on suction, because that keeps the lung expanded and that bleeding also decreases. How do we prevent air leaks? Prevention, there are various measures. Pleural tenting is one of them. Prophylactic intraoperative pneumoperitoneum following lower lobectomy. Surgical sealants on lung surface is a controversial topic. Buttressing the stipple line, phrenic nerve crushing, or limited thoracoplasty, all of these measures have to be decided by surgeon in a given case only. But in most of the cancer surgery, these things should not be required. Only if the space problem is likely to take place, then one thinks of a limited thoracoplasty. And most of these measures have been developed during the course of development of tubercular or inflammatory lung surgery. But they are useful in a given case of lung cancer surgery too. Thank you. I think I leave time for discussion and other things.
Well, thank you, Dr. Dewan. Am I audible, sir?
Yes, yes, absolutely.
You're audible, sir. You're audible.
Sir, thank you so much, Dewan, sir. And it is really a pleasure to chair a session in Dr. Dewan's presentation, who's a friend, philosopher, and my mentor also. Thank you very much, sir, for such a simplified presentation of such a complicated thing. Well, now I request Dr. Prashant to present his deliberation on role of surgery in small cell lung cancer. Dr. Prashant, please.
Hi, first of all, good evening all. I would like to thank the organizing secretary. I'm not able to share screen. Can it be allowed?
You will be. Just give it a minute. You will be.
Yeah, sure. Thank you, Dr. Shubham, and thank the entire organizing committee for giving me this opportunity to talk on role of surgery in small cell lung cancer.
Try now, Prashant.
Yes. Yeah. So I'll try to keep it brief, as the top. There's nothing. I mean, it's an important topic because, but unfortunately, we don't get many of these small cell lung cancers. As you see, just a second. Yeah. Okay. So it constitutes about 15% of all lung cancers, and we know that the biology is completely different from non-small cell. That is why we are debating why we should do surgery even in early stage. And unfortunately, as I said, only 3% of small cell actually present early, unlike the non-small cell. And is there a role? Why are we even talking about role of surgery? Is yes, sometimes because we know that about 30 to 50% of the small cell lung cancer following a concurrent chemoradiotherapy does have local recurrence and occasionally can be managed by surgery at that point of time. But actually, what are the indications? I see probably the only indication is the T1, T2, and when I say T2, up to only 5 centimeters and N0, M0. Surgery alone is never adequate, unlike non-small cell cancer, where surgery alone in early stage could be one of the best modalities for cure. As seen in the British MRC and the MSKCC, which comes from the database, surgery alone, very dismal outcomes with a 5-year survival rates of around just 1%. So how do we select a patient among this T1, T2? These patients should be extensively evaluated for nodal and metastatic disease, and we have to ensure that they are N0 and also M0 by PET CT, MRI, and invasive mediastinoscopy if necessary after and over and above an endobronchial ultrasound to ensure that we are dealing with an N0 disease and not an N1 disease where surgery may be futile if patient turns out to be N1. So there are a lot of studies. Most of them have been retrospective, as you see, or prospective study designs with very small numbers. As I said, the numbers are small because the incidence of these operable ones itself is about 3%.
Can I
And I think one.
I'm in a webinar.
Okay, so the most of these are retrospective study designs, and the 5-year survival rate is sometimes impressive among those patients who have undergone surgery in the prospective as well as the retrospective studies. There's one randomized controlled trial which we see. This is post-induction chemotherapy. Is there a role of surgery? This had both early as well as advanced tumors. There was no survival difference among these patients. So how do we say that there is a role of surgery? Is mainly only because of the prospective and retrospective. And I don't think conducting a randomized controlled trial is going to be challenging, keeping the numbers as the numbers are slightly on the lower side. So surgery should always be a part of multimodality treatment. And what is the evidence we have? We have 2 propensity matched analysis studies which show that they could benefit, stage 1 patients could benefit with surgery and as a part of multimodality, but never surgery alone, as I've already mentioned. So this is a study from Vekiam et al., where about 29,000 odd patients and 2,089 matched small cell lung cancers who had undergone surgery. Among those, if you see, the stage 1 patients definitely had a better overall survival than compared to those who did not undergo surgery. This was not, however, though the p-value is statistically significant, but this significance is not much seen in stage 2. So, and it also said that those patients who have received adjuvant chemotherapy, so these were about, all those patients who have received adjuvant chemotherapy was about 500 odd patients in this 2000. And they said lobectomy with adjuvant chemotherapy was associated with significant longer survival. And as you can clearly see, the median overall survival is almost close to double when surgery was not offered. So surgical resection is associated with significantly longer survivals. And another propensity matched analysis, I think probably these are the only 2 trials wherein we could bang on and say that, surgery definitely has some role in small cell lung cancer. So the second propensity match, which included about 863 patients, which showed that surgery was associated with an improved 5-year overall survival, where it jumped from 16.8 to 36.7%, and lung cancer specific survival was also much better. And interestingly, they found that even in N1, N2 patients, the survival benefits were significant in almost all groups. But however, when the tumor size was more than 5 centimeters or an advanced T stage, there was absolutely no benefit in surgery. So these are some of the databases from where where surgery versus no surgery for small cell lung cancer. And as you see, the 5-year survival, some of them have reported and makes. So as you see, the survivals are slightly better when compared to having no surgery. And most of these had early stage small cell lung cancers. As I said, surgery after induction, no survival advantage compared to concurrent chemoradiotherapy. But however, interestingly, few observational studies have shown an excellent 5-year and 10-year overall survival ranging between 29 and 23%, which is probably not the case even with definitive concurrent chemoradiotherapy. NCCN also recommends in a patient with stage 1 to 2A, those patients who are pathologically mediastinal negative, lobectomy and mediastinal lymph node dissection or sampling is preferred and followed by systemic therapy depending on the nodal staging. So to summarize, surgery for small cell is indicated only in T1, T2, N0. Mediastinum should be staged adequately prior to surgery. Adjuvant chemotherapy is mandatory unlike the non-small cell and improves outcomes significantly. For PN2, adjuvant radiotherapy is mandatory and PN1 role is controversial. Thank you.
Thank you, Prashant. I think that was a very elegant talk. Nice to see you after a long time. And very interesting talks in this session, 3 interesting talks. And I would like to thank Dr. Shubham and Harit sir for the opportunity to witness this entire event. And the next topic is surgery in metastatic lung cancer, how to choose the right patient. And this would be given by one of a pioneering woman thoracic surgical oncologist from the prestigious Tata Memorial Center in Mumbai, incidentally my alma mater as well, Savita Jivnani. She's made this profession proud, and I think we are looking forward to more from you, Savita. So looking forward for your talk and many more milestones in this thoracic oncology field as well. Over to you, Savita.
You're muted. Savita, you're muted.
Yeah. Can you hear me now? Can you
Yes,
see
go
my
ahead.
screen?
Yes,
Very
Savita.
well, very
Go
well.
ahead, go ahead.
Thank you, Arvind, for such a kind introduction. So good evening from Mumbai, and I hope everyone is staying safe and staying well. Today, I'm going to talk about surgery in oligometastatic lung cancer. And to start with, we need to know, my slides are not moving. Is there a problem? Okay. So we need to know what this oligometastatic disease is. Basically, it's a transitional state between localized and widely metastatic disease. And it was a concept that was introduced in 1995 by Hellman and Weisselbaum. So a lot of molecular theories, and it was ranging between Fisher's theory, and everyone knows about Bernard Fisher's theory about breast disease. So there were some questions which came up after 1995 when this concept was introduced. Does this state exist for lung cancer? Can we offer local therapy to these patients? How do we select the patients? How do we sequence the various modalities? And now recently, after targeted agents, what is oligoprogressive and oligorecurrent disease? So coming to the first question first, does a true oligometastatic state actually exist? So we all know that lung is the most common site of metastasis from other sites, and the International Registry of Lung Metastasis had published more than 5,000 patient data outcome where there was 36% 5-year survival after pulmonary metastectomy. We also know that 60% of non-small cell lung cancer patients are metastatic at present, 45% will become metastatic at some point, 15% of these are oligometastatic, and we also know that 1.8 million patients are diagnosed with lung cancer every year. So this means more than 200,000 patients worldwide. When I was looking up the literature for this talk, interestingly, I came upon this paper which was published in 1986 in Annals of Surgery. So we, the thoracic surgeons and our neurosurgical colleagues, were actually treating oligometastatic disease before this term was defined. This was an experience of 25 years from 1960 to 1985, which showed there was a median survival of 27 months if you excise brain mets from non-small cell lung cancer. And the early evidence for management of oligometastatic disease comes all from surgical studies. There was a paper in 1990 in NEGM where when surgery was added to whole brain radiation, which was the norm for brain metastasis at that time, the survival went up from a mere 15 weeks to 40 weeks. And also in 1995, Luketic published his results in Annals of Thoracic Surgery, treating different extrathoracic metastasis in patients with non-small cell lung cancer, and he showed that a few could survive up to 5 years. So what is the role of surgical management in this stage of disease? It was the first modality to be used. It is usually used in combination with other treatments. It's well established for a single lesion, for a solitary organ lesion, and the previous published literature mainly consists of literature for brain metastasis, adrenal, and lung metastasis. But always a survival benefit has been demonstrated. So why are we talking about this oligometastatic disease now? Why are all the international conferences having a separate section on oligometastatic disease in lung cancer? Like the World Congress of Lung Cancer last year actually had 3 dedicated sessions on this topic alone. So we all know now we have better means to stage our disease, surgery has become more sophisticated, and our patients have better systemic treatment options. All this has led to superior overall outcomes. And also this was noticed by the AJCC, which has divided the M stage into 3 because there was a distinct survival difference in patients who had single metastasis versus those who had multiple metastasis. Caveats of discussing this data are that the quality of data is really questionable. there has been a publication bias, only selecting the good risk responders, and the overall survival calculation, let's not even go there. So coming to brain metastasis, where this story actually started, 10% of patients will have brain metastasis as initial diagnosis, and the treatment options have traditionally been surgery, stereotactic radiotherapy is now coming in, and whole brain radiotherapy. So this was the largest series, a retrospective series of more than 100 patients who underwent neurosurgical resection, and all those who had R0 resection actually had a good survival. They also looked at, interestingly, the nodal stage in the thorax, and they saw that those who were N0 had a better survival than those who were N+. So all these early series told us that there were impressive results. There was also randomized evidence, and there were survivals in patients who presented with metachronous metastasis. Even synchronous metastasis did well when they were N0. So in 2012, Lisa Villacruz actually summarized all these studies together. She published this paper where all retrospective case series of patients with surgically resected synchronous metastasis from non-small cell lung cancer were clubbed together, and then she defined these patients by nodal stage. And we saw that the nodal stage in the mediastinum was actually the most important predictor of survival in these patients. When we come to adrenal metastasis, 3.5% of the patients present with adrenal metastasis. They have poorer prognosis compared to brain metastasis, and again, there are multiple retrospective series. Summarizing these retrospective series in the same paper, we saw that the prognostic factors were slightly different. Metachronous adrenal mets did better than synchronous, ipsilateral adrenal mets did better than contralateral, and minimally invasive surgery was also acceptable for these adrenal metastases. Soon after, in the next year itself, there was a systematic review. Like as usual, when we don't have great evidence, we look at systematic reviews or meta-analysis to find some answers. Here we saw that they got a summary of 49 studies with more than 2,000 patients, and of these, 82% actually had a control primary. So this was an important factor, that the primary in the lung needs to be controlled. The median age was relatively young. Surgery was used in 55% of the patients. 63% studies only reported survival, which had a very wide range. Also, we can see that brain metastasis was predominant, the number of metastases was limited, and adenocarcinoma was the favorite histology. So, looking at the outcomes, the survival outcomes were really heterogeneous. 5-year survival ranging from less than 10% to more than 80%, and more than 50% patients had failed locally or distantly in 12 months. So they also did a multivariate analysis, coming up with some risk factors, some prognostic factors, some of which they said were highly significant, like a controlled primary tumor, and others were occasionally significant, like the age, the number of metastases, and the use of chemotherapy. So the same group then went ahead and got the individual patient data from the various investigators. They got about 700 patients, and they tried to study them more in detail to see whether the surgery for oligometastatic disease and the local treatment actually helped these patients. So these were around 750 patients. They had a low burden of intrathoracic and metastatic disease. 2/3 of the patients were in stage 1A or 2B. 80% had a single synchronous MET. Only 3% had multi-organ metastatic disease, and METs were treated surgically in more than 60% of the cases. But look at the 5-year overall survival, 29%, quite good. So they also came out with some kind of risk groups, low risk, intermediate, and high risk, mostly depending upon the presentation of the metastasis and the nodal status. So we know now that the patient selection is the key determinant of survival in this group. We have to have definite control of the primary tumor, and the end stage in the thorax is the most important prognostic predictor. So after all this evidence, we knew that the treatment of oligometastatic disease was essential, gave a good survival, and should be tried whenever possible. But in the last 2 decades, we are also faced with treating our patients with targeted agents, especially those who are mutation positive. And then there was a term which came up in the last 5 years, which is known as oligoprogressive disease. So this actually means distinct clonal evolution at each site of the metastatic disease, independent of the primary site. So there is a EGFR mutation positive tumor, and the patient is taking erlotinib, but The primary has responded, but there are some small metastases which continue to grow and progress and are non-responders. So what do we do there? There comes in the role of local therapy, either in the form of surgery and nowadays SBRT, which does not delay the treatment much. And afterwards, when the resistant clones are removed, the patient again becomes sensitive to the systemic therapy. So this was an important study that came up in 2016, which addressed this issue. It was a phase 2 multicentric trial, which was seeking to enroll 74 patients. And these had to be stage 4 non-small cell lung cancer with 3 or less lesions persisting after first line of systemic therapy and no disease progression. They were randomized to either get only systemic therapy or be randomized to get local therapy. The primary endpoint was progression-free survival. But what happened? This study was closed after an early interim analysis. Look at these survival curves. The patients who received local therapy did much, much better. The median follow-up was 38.8 months, but there was a definite difference in the overall as well as the progression-free survival. There was no increase in any adverse events because of the local treatment. And after this study was discussed and presented in ASCO, it led to a flurry of trials which flooded the clinical trials website. And as of now, there are 34 trials which are recruiting oligometastatic disease, such a rare subset all over the world, using various combinations of local treatment and systemic treatment. But now, because of so many studies, there have been differing definitions, different staging procedures, and it is going to be extremely difficult to compare results and reach a consensus. So a pan-European multidisciplinary consensus group was formed, which had 35 European thoracic oncology experts, and they actually formed a consensus statement and studied a lot of scenarios over 2 years, and they came to this definition. Radical treatment is technically feasible with acceptable toxicity, with all sites being amenable to local treatment. Look at the terminology that they have said. They have said this will modify the course of the disease, and this can be considered as an opportunity for long-term disease control. They did not use the term cure. They said long-term disease control and modifying the course of the disease. And this is what we need to explain to our patients also when we offer them this treatment, which is based on very, very low level evidence. So they also said mediastinal lymph nodes are not metastatic. We have to rigorously stage our patients. There has to be dedicated imaging for special subsites. Pathological confirmation may be required. They also said this has to be only 5 metastases in 3 organs max, and some sites were excluded from being included in this oligometastatic non-small cell lung cancer. This was presented in the 2019 World Congress of Lung Cancer last year. And in 2020, NCCN came up with the new guidelines of treating limited metastasis disease to the brain and also in the thorax. And again, the confusion started. How do you sequence the multimodality treatment? Do you give systemic therapy first? Because after all, we are talking about stage 4 lung cancer, or should we do local therapy first? Well, according to me, it needs to be tailored according to the patient factors, the tumor factors, and the expertise that is available at your center. And it has to be a personalized decision for every patient who comes with this unique set of disease. So concluding, selected non-small cell lung cancer with distant metastasis, these patients can now be offered cure. Metachronous presentation, control primary, and N0 status are good predictors. In there, we are going to see a large number of these oligometastatic patients now because of improved imaging, because of molecular diagnostics, and the leaps that systemic therapy has taken in the last 2 decades. Aggressive local therapy is already an integral part of stage 4 lung cancer, and we need to select our patients properly, sequence the therapy properly, and avoid toxicity so that we can actually give them some kind of long-term survival. Thank you very much for your patient listening. And just before saying thank you, I would like to invite you all to this multidisciplinary lung cancer management course that we are conducting along with PGI Chandigarh and ASCO in December over 2 weekends, and also our annual OncoSurge, which is coinciding on one of the weekends. Thank you so much. Thanks a lot.
Thank you, Savita. That was a very complex topic, and you really elegantly covered it within about 10 or 11 minutes. just have one question to ask. Can you share any of the TMH experience in oligometastatic lung disease? I was wanting to know
So
that.
actually,
That
one
is
of our fellows is actually presenting a poster on oligometastatic non-small cell lung cancer. You can view it in the e-posters. We looked at our own data. We have had 12 patients that we have treated over the last 10 years. And most of them have had brain metastasis. 3 of them have adrenal metastasis. And the longest survivor was actually survived for 51 months. And the median survival, I think, is around 18 to 20 months. So it's reasonable and it's good. But we have done mediastinoscopy for all of our patients, staged the mediastinum well, and only if they are less than N2, then we offer them therapy for both the primary as well as the distant med.
these are all surgically treated patients, you mean?
Yes,
So,
surgically treated
so
patients. This is
are
from
there
our surgical
are there a cohort of patients that have been treated with SBRT as a local modality?
Yes, there are patients, and also there have been a few patients now in the last 2-3 years who have been on systemic therapy and they have oligoprogressive disease, which are currently on treatment with SBRT, and this data is going to come out soon.
Great. Looking forward for that data in this very, because we look to you for such data. Like it's very difficult for other institutes to provide this data.
Thank you so much, Arvind. I tried to make it in a chronological order because when Shubham gave me the topic, I was like, oh my God, how am I going to do this? But I just took it year-wise and it, I think, came along quite okay. Thank you so much.
Yeah, Sabita, yeah, it was a very nice presentation. I think this is one field where the surgeons should be actively taking part in metastatic setting. This is a very small group of settings. We usually tend to move away from metastatic disease. I think this is one opportunity for especially for brain and for adrenal. I think we should be very aggressive for the local control part. I mean, surgery
Definitely, Dr. Darlong, with SBRT and Durvalumab taking over all our curative
yes,
patients,
we have to push
aggressive.
pitch in that the surgery is definitely, I mean, one of the modality. It should be, I mean, the choice should be given. It should not be straight away they say you go for SBRT. I mean, we should say you have to give the option of surgery. Just like in early stage, they were saying, I mean, SBRT going to take over. I don't think that is going to happen. I mean, we are also getting more and more less invasive and things are getting safer and anesthetic techniques are getting very, very safe. And so this is one area I think that we have to again be fighting with SBRT in this.
Definitely, Dr. Darlong, we have to, and we are the pioneers of treatment in this setting. So we have to.
Because we are doing regularly for oligometastatic brain disease, we have got a very good coordination with our radiation oncologists and medical oncologists. So it comes up in our MDT. Otherwise, I mean, if the surgeon is not involved, I don't think it goes to them also in other setting.
So Dr. Kumar has a question. When are you going to start operating T4 lesions with more than one tumor in one side? Sir, if it does not require a pneumonectomy, definitely we should consider it. But if it ends up requiring a pneumonectomy, the morbidity of that disease actually precludes giving this treatment.
Sabita, I would like to add one point. I think we should not take pneumonectomy as an absolute contraindication, especially if you're doing on the left side.
Right, right.
So thank you, Chairperson and all the speakers. We are running short of time. So now I would like to invite Dr. Jyotika Jain, Senior Consultant and Head Radiation Oncologist at Venkateshwar Hospital, Delhi. And the next chairperson is Dr. Manoj Dayal, Senior Consultant Radiation Oncologist from Medanta Hospital, Delhi. Over to you, sir and ma'am.
Hello. Thank you, Dr. Rashmi, for inviting me for this wonderful feast, basically. So now we'll move on to the next session. Now I am going to invite Dr. Kundan Shepherd. He is going to present SRS in brain metastasis number and time. What's the limit? Dr. Kundan, please.
Yeah, am I audible?
Yes.
Yeah, I'm just trying to share my screen here. Just a second. So you all can see the slides.
We can see the slides, Dr. Kundan.
So good evening, everyone. So at the outset, I would like to thank the organizers, especially Dr. Shubham, Dr. Charu, Dr. Harit, and all the organizers for giving me this opportunity and rather very interesting topic here, though I have modified a subject a little bit. So the relevance of this topic, stems from the rapid and very gratifying improvements in survival observed in this patient population. This allows more time for brain metastasis to develop and for patients to face the consequences of radiotherapy. So while in the recent past, the appearance of brain metastasis prompted reflex whole brain RT, we move towards stereotactic radiosurgery. So there is now irrefutable evidence that mutant non-small cell lung cancer have a higher rate of brain metastasis. And for a while, we were comfortable with sequencing stereotactic radiosurgery followed by TKI. But with the emergence of CNS penetrating TKIs, the optimal management is again in a state of evolution. And with the emergence of immunotherapy, I anticipate that it is going to get a lot more complex. Though I will be addressing specifically a mutant non-small cell lung cancer, because of paucity of time, I will not be covering the immunotherapy part also. So, but before we delve into this topic, let's take a glimpse at the spectrum of survival in this group of patients. And it is astounding to see that that some patients can survive up to 4 years after being diagnosed with brain metastasis, when just 2 decades ago, we expected only half a year of survival. Maybe some people might disagree, but this progress has been the result of concerted efforts made by both medical and radiation oncologists. So the journey from whole brain radiotherapy to SRS is a lecture on its own. But keeping in mind the multidisciplinary members of this meeting, I will stick to the key highlights. While it is currently fashionable to criticize whole brain radiation for its shortcomings, it has served us well in the past. So before the turn of the millennium, whole brain radiation was all we had, and it offered something to the patients and their families. With the development of SRS, early results suggested that it had an incredible local control rate with several advantages over whole brain RT, but had a higher intracranial failure rate, which is why investigators focused on adding whole brain radiation to SRS. But a meta-analysis by Dr. Sahgal, in which almost 60% of the patient had lung primary, this meta-analysis cemented the place of SRS in the management of 1 to 3 brain metastasis. And with increasing utilization of SRS and declining whole brain RT trends, survival in large database analysis, it doubled. And the Quartz trial suggested a diminished role of whole brain radiotherapy, though this trial has its own flaws. So an alternative whole brain technique was developed, which preserved neurocognition by sparing the hippocampus, while simultaneously delivering a higher dose to a macroscopic lesion. And I hope this topic of hippocampal avoidance will be dealt by Sayan in his next talk. So I'm just not going into detail of this thing. But interestingly, you will notice here that this timeline ends somewhere around 2017. And its significance I will reveal in my next few slides. With that background, we turn our attention to a mutant non-small cell lung cancer. I was overjoyed to see that that sequentially delivering tyrosine kinase inhibitors in mutant NSCLC after SRS was further improving outcomes for our patients. And across diverse population, you can see in all these trials and agents, we were seeing near doubling of survival and were phasing out whole brain radiation from our algorithms. We also understood that concurrent TKI with RT is not a good idea due to higher risk of radionecrosis, as many of these series actually revealed this thing. All was going well till around 2017. Medical and radiation oncology were finally coming together, but a tsunami was coming. And this tsunami of data on next generation TKIs. Their impressive extracranial activity was matched with the data suggested that they were effective in preventing intracranial progression in patients with asymptomatic brain metastasis. While reviewing the literature of all these trials, I contemplated describing every trial in some detail, detailing individual relative risk and hazard ratio for each agent, and trying to draw some meaningful conclusion for this audience to take home. And instead, questions came to my mind. Were these trials powered adequately to answer the question of sequencing, or were they byproducts of exploratory unplanned subgroup analysis? Is there a reason why only a minority of them report objective local control rates, and why details of delivered RT were unreported, though they were allowed? And finally, all these trials did not compare survival or progression-free survival head-to-head with SRS. So if these trials were not designed to answer the question of sequencing, I would rather consider their conclusion of postponing SRS till progression simply hypothesis generating, not practice changing, though many will not agree. And we can argue this debate till results of some of these ongoing trials in Australia, Canada, and America are published. And perhaps next year, I might be talking about how I was misguided in my current opinion. But till that time comes, let's look at this meta-analysis, which was specifically designed to study the sequencing of SRS and TKIs, published in Green Journal last year. There are many other meta-analyses, but I have included this one because this is a recent one. And also it included some of these next generation TKIs, CNS penetrant TKIs. So the population was predominantly EGFR mutant rather than ALK mutant, reflecting the real world distribution of these mutations. And sequential SRS and TKI improved progression-free survival by 5 months, missing the significance mark by just 0.01. The difference in overall survival, though, was not significant. So looking at this high quality multi-institutional data where the trend towards improvement in progression-free survival was there, I am compelled to predict that similar to the trials of SRS and whole brain RT, where appearance of new metastases were prevented by whole brain RT, resulting in improved intracranial progression-free survival, adding TKIs to SRS will also improve intracranial progression-free survival in mutant NSCLC. And essentially, TKI could replace whole brain RT in our algorithms. But the premise of this approach rests on the question, what is the limit of SRS? And this is the topic of my talk, the next part of my talk. And if you ask this question to head of the Japanese Lexel Gamma Knife Society, Dr. Yamamoto, and review his literature, there are no limits on the number of lesions which can be treated with SRS, as far as his opinion goes. The pivotal JLGK0901 study is revered in the radiation oncology community as the first of its kind, proving that patients with 2 to 4 brain metastases had equivalent survival to those with 5 to 10 brain metastases. And this came a full year before Segal's meta-analysis, which made SRS the standard of care for limited brain metastases in America and Europe. And a full 5 year later, Hughes et al. Replicated the results of Dr. Yamamoto in an American multi-institutional analysis, suggesting that the survival of 2 to 4 and 5 to 15 metastases were equivalent. Pushing the envelope even further, Dr. Yamamoto in his next analysis proved that patients with 2 to 9 metastases enjoyed equivalent survival when compared to the range of metastases, which ranges from 10 to 63. So this was quite astounding. For brain metastases arising from non-small cell lung cancer, his group replicated the results of JLGK901 study in this particular group of non-small cell lung cancer. And interestingly, if you look here, when substratified by the time of treatment, these patients received after SRS, TKI or TKI followed by chemo, which was given on progression, it was statistically equivalent. Since these TKIs were first generation TKIs, consider the possibility of adding next generation TKIs to SRS, as I had shown you in my previous slides. So it is not implausible to assume that our current preference of radiotherapy technique based on numbers alone will evolve from hippocampal avoidance whole brain RT for more than 4 metastases to more than 10 metastases. And there is an emerging endorsement for this approach from the American Radium Society, announced just 1 month back in their annual conference. And hopefully ongoing head-to-head trials comparing SRS with whole brain RT will answer this question in the near future. But before we all head back to our clinic on Monday and start irradiating up to 10 metastases with radical intent, let's for a brief moment also consider the limitations imposed by technology. Dr. Yamamoto's result arise from a long experience with working exclusively with Gamma Knife, a single purpose delivery platform designed exclusively for intracranial treatments. And advances in technology like CyberKnife and linear accelerator-based SRS platforms have wider availability and applicability. And as our experience with these platforms increases, we will appreciate the inherent trade-offs associated with each technique. In the interest of time and to maintain the attention of our multidisciplinary audience, suffice to say that SRS planning and delivery is not an easy endeavor. From my own experience with delivering SRS for a single patient, I can safely say that it requires at least a full working day to create a high quality deliverable plan. But eventually, it is immensely gratifying to see the hard work pay off. In last 2 years, we have treated 127 brain metastases in 58 patients with up to maximum of 4 lesions per patient. We are in the midst of analyzing our results and we anticipate sharing them soon. So to conclude, we try to follow this algorithm. Specifically, if we focus on symptoms, asymptomatic TKI naive, where the visceral crisis or a visceral extracranial disease is not much, not alarming, and the metastasis ranges between 1 to 4 brain metastasis, we try to convince our medical oncologist colleague, and specifically Dr. Ullas is there, you all can understand how difficult it is to convince him. So we have to convince them to go ahead with radiation first, followed by TKI. But if the lesions are more than 4, or if somehow not amenable for SRS, then probably we try to avoid whole brain radiation as far as possible. Well, things are not so simple as it seems to be, and you would comprehend it fully if you witness our multidisciplinary tumor board, as Dr. Darlang was mentioning earlier. So to add to this complexity, financial status of the patient also plays a major role in decision making. I think Dr. Kumar Prabhash will be talking about that also. Making decision difficult for both with regard to choices of TKIs and the technique of radiation. So finally, this topic is ever evolving and we will have to adapt to this rapidly changing landscape. It is so heartening to see that we are discussing the management of NSCLC with brain mets so that we have prolonged survival along with good quality of life, while 2 decades back, this same scenario was considered as lost battle. Hopefully, there's still a lot to come and future may unlock our limitations in treating and further improving outcome in these patients. Thank you.
Thank you very much, Dr. Kundan, for such a wonderful presentation. So I think Dr. Manoj will be inviting for the second speaker, Dr. Manoj.
Yeah, so now I invite Dr. Sayan Paul to give his presentation on whole brain RT with hippocampal sparing when not. So I think further questions will take after his talk. There are some questions to arise, obviously. So over to Dr. Sayan Paul.
Am I audible?
Yes, you are audible.
Yeah. Can you see my screen?
We can see your face.
In a minute.
Yeah. Just let me. I'll share it. Yeah. Now, can you see my screen?
We can see, Sai. We can see.
Yeah. I'm making it full screen. So, good evening, chairpersons, delegates, and faculties. And at the outset, I thank the NELCON organizers and Dr. Charu Garg for giving me the opportunity today. So, in next 15 minutes, I'll try to show whatever knowledge and evidences I could gather on this topic, whole brain radiotherapy with hippocampal sparing when not. So, how many of you can identify this famous person or this famous neurosurgeon? I know who are interested in neuro-oncology can readily recognize these two persons. Yes, this is the famous patient, Mr. Henry Molaison, and the famous neurosurgeon, Dr. William Beecher Scoville. So how they are related to this talk? In 1953, Dr. Scoville did a surgery on Mr. Henry Molaison for intractable epilepsy. And the surgery was bitemporal medial lobectomy. So what happened after that? The patient HM after the surgery was studied extensively, and most of our knowledge on the function of the brain is actually the contribution of patient HM. After the surgery, the patient developed anterograde amnesia. That is, he could remember whatever he memorized before the surgery, but he could not register any new memory. So that is because his hippocampus was removed during this surgery. Hippocampus is a paired organ and part of the puppet circuit, and it is the responsible for storing and recollecting the memory. Whole brain radiotherapy was considered as a palliative technique for terminally ill patients, but recently, with improved survival, with novel systemic therapies, the quality of life of the patient has also become a very important factor. And this article, published by Dr. Vinay Gonde in 2014, called RTOG 0933, changed our outlook on whole brain radiotherapy. This phase 2 trial, preservation of memory with conformal avoidance of hippocampal neural stem cell during whole brain radiotherapy for brain mets, showed that there is 30% reduction in neurocognitive toxicity compared to historical control if the hippocampus is avoided during whole brain radiotherapy. And the same group did a phase 3 trial, Energy CC001, comparing hippocampal avoidance with whole brain RT and memantine and non-hippocampal avoidance with memantine, whole brain radiotherapy with memantine. And they have shown that hippocampal avoidance prevents cognitive function failure with 26% relative rate reduction. And it starts at 3 months and was continued throughout the follow-up period. And they concluded hippocampal avoidance during whole brain RT plus memantine for brain metastasis better preserve neurocognitive function and patient-reported outcomes while achieving similar intracranial control and survival. But we need to keep in the mind that they excluded all the patients who had hydrocephalus or ventricular distortion, and all the patients were undergone 3D MRI. So question is, how many of our patients will be eligible for this? Mainly the elderly patients. But the impact of this trial was so much that NCCN in their guideline mentioned for brain metastasis, patient eligible to receive whole brain radiotherapy and whose survival is expected to be 4 months or longer, hippocampal avoidance using IMRT should be considered standard of care. So as this is a lung cancer conference, I'll discuss only the scenarios associated with lung cancer. So we have two situations. One is prophylactic cranial radiation for small cell lung cancer and another for brain metastasis. So for PCI in small cell lung cancer, can you spare the hippocampus? So this is a safety profile study done by Dr. Vinay Gandhi in 2014 with 70 patients data and showed that the overall incidence of hippocampal metastasis before or after whole brain radiotherapy in small cell lung cancer patient is actually low. This data preliminary support for safety of hippocampal avoidance during a planned clinical trial of hippocampal avoidance whole brain RT for small cell lung cancer. And this is another bigger data of 120 patients with 754 mets presented in ASTRO 2018 from Australia showed that there were 22 patients with hippocampal metastasis. That is 18.3% of their cohort. And total 23 metastases involved the hippocampal avoidance area. And they concluded that overall incidence of hippocampal metastasis in their cohort of SCLC patient is high, as hippocampal sparing whole brain RT may increase the risk of treatment failure in the spared region. Prospective randomized trial are encouraged. So these, in ASTRO 2018, two very important abstracts of phase 3 trial of PCI with or without hippocampal avoidance was presented back to back, one from Netherlands and another from Spain. So the Dutch randomized phase 3 trial of 168 patients investigated the safety and reports on the incidence and location of the brain metastasis after treatment with hippocampal avoidance PCI compared to standard PCI. With a median follow-up of 24.6 months, there was no significant difference in the incidence of brain metastasis between the two arms. None of the patients developed a single brain metastasis in the hippocampus or hippocampal avoidance area. And the second one is the Spanish Premier trial data. A result of 118 patients shows there was a significant decline in memory in PCI group. Further investigation to assess its impact on long term is actually going on. The Dutch group in ISTO 38 2019 presented their preliminary result. and showing that HVLT-R total recall score was more than equal to 5 points lower compared to baseline, and it is 28% in PCI group and 29% in hippocampal avoidance PCI group at 4 months. The p-value was not significant. Even at 8 months, it was 34% and 26%, and at 8 months also the p-value is not significant. And they concluded there is no significant difference between the two arms was seen. The incidence of brain recurrence was also not increased in the avoidance area. So now all eyes are on this ongoing energy CC003 trial by Dr. Sem Binoy Gandhi and team. And this is a randomized trial of PCI with or without hippocampal avoidance. Following accrual of 182 patients in phase 2, they have analyzed the phase 2 data, and they have again accrued 122 patients, and the trial, phase 3 trial is going on. So let's see what Astro Clinical Practice Guideline 2022 says. Strategies to reduce the risk of neurotoxicity, including medical intervention and hippocampal avoidance PCI, are currently being assessed in ongoing clinical trial, that is Energy CC003, and the rate of brain metastatic failure from this approach is yet to be defined in this population. So as per available evidences, till date, we cannot practice hippocampal avoidance PCI in SCLC in our clinic. Now for brain metastasis, the stage has already been set by my favorite senior, Dr. Kundan Singh Chofal, so making my job very easy. This trial shown by Dr. Kundan Singh Chofal is a meta-analysis by Dr. Arjun Sehgal, and what they have shown is they established SRS as standard of care for patients less than 50 years. It's 1 to 4 brain metastasis, and 59%, that is total 214 patients of lung cancer was there in this cohort. And this trial, this data also as shown by Dr. Chopal is a Japanese trial data of 1,194 patients, and they have shown in 3 groups, 1 metastasis, 2 to 4 metastasis, and 5 to 10 brain metastasis, non-inferiority of SRS alone for patient with 5 to 10 brain mets versus 2 to 4 brain mets. And this is a very interesting analysis. It was published in 2019 by Dr. Binay Gondi on the same RTOG 0933 data, and see what they have concluded. In patient receiving hippocampal avoidance whole brain RT for brain metastasis, extent of pretreatment white matter injury predicts post-treatment memory decline. That suggests a mechanism of radiation therapy-induced neurocognitive toxicity independent of hippocampal stem cell radiosensitivity. Stability or improvement in HVLT after hippocampal avoidance whole brain RT for patients with higher pretreatment intracranial metastatic burden supports the importance of whole brain RT-induced intracranial control on neurocognition. So, clearing the hippocampus may not be enough in some cases. Radiation-induced cognitive impairment likely involves dynamic interaction between multiple cell types in the brain. Brain irradiation causes changes in the vasculature, glial cell population, hippocampal neurogenesis, altered neuronal function, and elicit neuroinflammation. All these pathways likely contribute to the development of radiation-induced cognitive impairment. So this is an ongoing Canadian trial, and it is actually comparing SRS versus hippocampal avoidance whole brain radiotherapy plus memantine for 5 to 10 brain metastasis. And probably will reach to some conclusion once the result is declared. So we agreed that dose to hippocampus is important to some extent for neurocognition, and theoretically any dose can produce damage to hippocampal neuroprogenitor cells. So let us compare from available data how much mean dose we can achieve from the existing technique. So for LINAC, it is 4.9 gray. In tomotherapy, whole brain RT, 7.3 gray. For proton, it is 4.4 gray, whereas for SRS, it is 1.6 gray. And if you do a hippocampal sparing, it is only 0.78 gray. So if we want to protect hippocampus, then why not hippocampal avoidance SRS? So let's see what the NICE guideline, which is followed in UK, says. They have said consider maximal local therapy, the surgery or SRS or SRT for single brain metastasis. Consider SRS or SRT for multiple brain metastasis where KPS is more than 70 and the extracranial disease is controllable. and do not offer whole brain radiotherapy to people with non-small cell lung cancer and brain metastases that are not suitable for surgery, SRS or SRT, and the KPS is less than 17. Because of the published QUARTZ trial, which shows that best supportive care with dexamethasone is non-inferior to whole brain radiotherapy in this group of patients. And they have also said do not offer memantine, which is also a neuroprotector, in addition to whole brain radiotherapy to people with multiple brain metastases, unless as part of a clinical trial. So in the
Dr.
clinic,
Sen,
yeah.
Dr. Sen, you have 3 minutes left.
Okay, fine, I'll finish, no problem. So in the clinic, when a patient with brain mets come, our medical oncology colleagues will have a basket full of options, multiple line of systemic treatment, and he will send the patient to a radiation oncologist. Then we are in dilemma, which technique to be used. In this regard, the health economics comes into picture. It is not only the cost of the treatment treatment technique, it also includes the travel and stay of the patient, the duration of the patient. Maybe SRS per se can cost more, but if you combine travel and stay of the patient for 2 weeks for whole brain RT, it might be costlier than SRS. And also we need to assess whether the patient has access to this immunotherapy targeted therapy. Is he affordable to do this? Will he or she be continuing the systemic treatment? Is there a compliance to imaging follow-up or physical follow-up? And is the patient affordable of retreatment? So considering all these factors, we need to decide which treatment to be offered, obviously with whatever available evidences we have in this scenario. So I again thank you, the NALCON organizers, and because of this topic, I could read this fantastic book, Patient AHM, written by Luke Dietrich. And you know who is Luke Dietrich? He is the grandson of our neurosurgeon, Dr. William Beecher Scoville. I acknowledge Dr. Impa Bosu Achari for guiding me for preparing this presentation. My friend, Dr. Bimoj Nair, who is a part of the Canadian trial, and he also guided me a lot, and Dr. Kanu Charan Patro. And thank you all for your patient hearing.
Thank you very much, Dr. Kundan, Dr. Paul. Because of shortage of time, we'll not be able to take any questions. I got a call just to conclude the session. So thank you very much for a wonderful presentation.
Thank you, Dr. Chopal. Thank you, Dr. Jyotika. Thank you, Dr.
Jyotika.
It was a nice
Thank you, Dr.
presentation.
Sai. Yeah.
Thank you. And I must really compliment Sayan that it was a very, very, very lucid presentation. And, I'm very happy that at least not just the attendees, but even the faculties had to read up and prepare a presentation, and it made Sayan at least richer in whatever his talk was on. And with this talk, we'll move on to, as you see the day progresses, we are moving from surgery, comparing it with radiation, and now to the final topic of the day, and something that we all need to take a backseat and listen to is what is Dr. Kumar Prabhash. Dr. Kumar Prabhash is going to take us through the journey of a Aam Aadmi with lung cancer, and we couldn't think of anybody better than Dr. Kumar to talk about it because of the sheer volume of patient that he sees, the sheer amount of work that he has done, and he is well aware of both the economic as well as the feasibility challenges of lung cancer treatment for Aam Aadmi. To chair this session, we have a very senior medical oncologist, Dr. Rakesh Chopra. I welcome him, sir, because he is also somebody who has seen over his lifetime how lung cancer treatment has progressed, and we would also want to hear his words. What I liked in science talk actually was at the last, there was these nice guidelines which said that if your KPS score is actually less than 70, you should take a step back and allow the patient to be the way the patient is with just dexamethasone and best supportive care. So looking forward to Dr. Kumar's talk. Dr. Kumar, please switch on your camera and your mic, sir, and you can share your screen as well. We can see you, sir, but your screen is not visible. Okay, great.
Can you see the screen now?
Yes, sir, we can see the screen. It's just coming up.
And can you hear me?
We can hear you well, sir.
Thank you, Subham, and thank you. I thank the Nalcon for invite, and especially Dr. Nitesh and Dr. Harit sir for inviting me. And it's nice to hear that Nitesh is recovering and doing better. That's a good news. Now I'll start with my presentation, and I have been
Sir,
given. Sorry, go ahead.
you need to stop share and reshare. It's not sharing, it's just showing screen sharing, but it's not. Just stop share and reshare once again, sir.
Stop share.
Reshare, sir. Yes, please.
You can see it now?
Perfect, sir. Perfect.
Yes. Yes. So I will do slides. So now you can see it. Is it okay?
Very well seen, sir. Very well seen.
So I have been given a bit of a twisted topic, but an interesting one. Aam Aadmi with lung cancer, and get me a cost-effective solution. I'm fortunate to work in a setup which allows these questions to come up, and this question comes up on a regular basis. I'm sure there are many people in the audience where this question comes up to them on regular basis, and sure they do have those solutions. So what I'll do is I'll share from my sides the solutions in this situation, what we have tried to do, and see what has been the impact. So this is a famous quote and the article by Dr. Gawali, and he wrote that the cancer ground shot, before we go to moonshot, and that is very true for us. Absolutely very true for us. Sure, we want that many of the treatment, which is very effective, which we heard the full day today and yesterday, many of them, how we can ensure that we know that many of the treatments are not so effective, and that's what the comment made by Shubham also earlier, and we want, okay, the patient gets or not, we are not so concerned. But many of those treatments who are very effective, how we ensure, how we see that those treatments or similar kind of treatment is delivered to our patients. Some of those issues which comes to my mind when I sit in my OPD, that doesn't mean these are the only issue of Aam Aadmi. I'm sure there are many more, but these are some of the issues where we could try some of those solutions. So I thought I'll share only those part of it. I'll love to hear from other people what they had it and how they had the solution, so we can learn from each other. For me, the issue is in a center, the way which center I work, being a government center, busy center, patient navigation has been a big issue. Same was when I was working in the medical college. I did my medical college from Maulana Azad Medical College. I'm sure people who are there from that, they will say the same thing. Patient doesn't know where to go, how to go, where to come, where thing happens. Second, access to available treatment. As we concede there are some very effective treatment, but we always wonder, as was commented by the last speaker, how many of them can take it. Third is for me, patient-centric early palliative care, because we did some work on it and we know this has been adopted in a big way, but are we adopting it rightly, and how do we ensure that this something which is so basic can be available to all patients? Poor performance status patients. Everyone will tell you we have 20% of our patients in stage 1, 2. Majority of the center, they operate around 5% to 6%. We have in our stage 4 patients, almost 1/5 of them, they present in PS 3 or 4, which we want to send them home. But remember, these are 1/5 of the whole patients. Shouldn't we find some solution for them? Distance of the treatment center. Majority of the center are located in big center and the remote places. How do we ensure those cares can be delivered to them, or finding a solution so they are able to take those treatment when they reach there? Development of cost-effective treatment. We do have treatment. Can we do some innovation? We know that we don't do much invention in India, as told by, it's not my statement. This statement was by Mr. Narayan Murthy, who is he was Infosys chairperson and the founder. But he did suggest that yes, we have a huge capacity to do some innovation. Let's see, can we do some innovation to find some solution for our patients where we can put some cost-effective treatment in their hand, where we don't get from multinational trials. And then development of the same is the cost-effective investigations. Can we do some innovations to do that? Starting with the first issue, this is the this is something we started with our work with, to understand what kind of problem we have in our population, that is in our center. This was one of the first paper where we tried to find the epidemiology, the kind of patients we have, the kind of stages we have, kind of performance status we have, and that gave us some sense of the kind of problem we are dealing with our patients. As I told you, that navigation was a huge issue, and this was one of those papers we suggested that it helps. We try to partner with our NGOs and social workers, and we kept asking many people, and as you can see here, the two of them, at least there are many of them who helps us out, but these two of them who came forward and they put in both our OPD, in the general side and the private side, person who are there full day to guide our patients how and where to go, when to come, where the scan is going to be done, where to make the payment, how you're going to access the line, the email. All these things are helped by them. And yes, I need to concede this has been hugely helpful for our patients. That doesn't mean we have solved the problem for all our patients. And this has also been acknowledged by our hospital. Our hospital has a KVAT program which runs for the hospital. And these are the people who supplement them to see that the patients are navigated well and they are available full day to see that the patients are able to go to the right place and get the right test and the treatment done. Next issue has been the access to treatment. Remember, cost is one factor, but there are multiple factors for access to treatment. And this we have been trying hard. Again, we realize apart from being a medical oncologist, we need to talk to many other people if we want to find this solution, as we talked about in patient navigation. So what we did, again, we realized a social worker and NGO, they are very important part in the management of our cancer patients. So we talked to our social worker department, talked to many of those NGOs that can we find support for these patients where we have effective treatment. Sometimes treatments are available free of cost, but the method is such that they are not able to get it. It is not easy, lung cancer being majority of being a realistic outcome, but we took the inspiration from our pediatric department. They have a very nice method of generating resources, and they raise the resources of in the range of 35 crores every year from donation. But they present themselves as a curable malignancy, and it is not easy for us to present that way. But persuasions to the NGOs helped us out, and as you can see here, the TMH Social Worker Department and the two other NGOs, We Care and Mother, they came forward to help the patient out to get those finances from various places, either from the BPL category where the a company which makes it gives free, or getting from the Prime Minister Fund, getting from the Chief Minister Fund, getting from Rajiv Gandhi Jeevan Dayi Yojana. The whole paperwork which is required, they facilitate and ensure that these patients get those treatments. Sometimes you do have the scheme on the paper, but the kind of paperwork and persuasion required, people don't get it, those treatment. And when we started this, before that, we realized that half of our patients, they are able to get targeted therapy if they had those mutation positive patients. Now, do we have a finding when we started this? This has changed. And as I can show you, these are ROS1 positive patients showing the outcome. But the important is 80% of the patients, they get treatment in this situation as a targeted therapy. Second one showing lorlatinib. This is the compassionate basis program where you get this drug, but is a huge amount of paperwork with DCGI. And this is totally, you can understand, these are the patients coming from the general side and private side, coming from far off, who doesn't know the whole paperwork, but again, done by the whole group of people sitting in the OPD from NGOs and social worker department who ensures it is done. For me, the most important has been this. We have treated almost 500 plus patients of ALK positive non-small cell lung cancer. And because of this program, 400 plus patients, that is almost more than 80% of them, they were able to get targeted therapy in this situation for these patients. And out of those, as you can see below, at the end in the table, almost 2/3, or I can say 60% of them, they got from not from the pocket or from the reimbursement. They got because this was arranged by the social worker department with the help of many other people who gave these funding to these patients. How important is this? This is important in the context of this JAMA paper. I'm sure many of us, many of you might have read it. And this JAMA paper in 2019 suggested that if you do have a EGFR mutation positive patients in US, then 64% of them, they got targeted therapy. The rest of them, they don't get targeted therapy. If you are ALK positive patient in US, then 70% of them, they get targeted therapy, and rest of them, they don't get targeted therapy. And if you do have some other mutations, then only 48% of them, they get targeted therapy, and rest of them, they don't get targeted therapy. Again, reminding this paper is from 2019. As I showed you in our setup, because of the help of many other people, we are able to deliver treatment to more than 80% of the patients in this setting. And for us, it is relatively satisfying. That doesn't mean we have achieved what we wanted to. We want to improve upon this, what we have been able to do it. Another issue what we have in Mumbai, and especially for our center, is that 75% of the patients are from outside, and accommodation is a key concern. Again, what we did, we tried to see, talking to people from outside oncology, requesting the NGOs and social worker that this is a huge problem. And because of this reason, many people are not able to take treatment, and we wanted transient accommodation. We had some very nice person who runs the Jilka Foundation, and he was very, Mr. Gogi, and he talked to us. We tried to impress upon him. We were not sure for lung cancer we will be able to impress upon some person. He met us, he said yes, and then for 6 months we couldn't meet each other. We thought maybe he said yes, and maybe lung cancer management and helping the patient lung cancer didn't excite him much. 6 months down the line, he came up with the accommodation facility which was made, and this is 14-bedded facility where people can live transiently there, and also there the food is free. This partly resolved our issue for accommodation for our lung cancer patient in this setting, and this was dedicated for lung cancer patient from his side. We also tried to find out if the people are living from far off, can we have a solution that they don't have to come to a hospital for every follow-up. This was a project led by Dr. J.P. Agarwal, and what they found that in curative setting, it appears that a telephonic follow-up is a good idea. We also did this work from our department in neurology setting, similar kind of patient as we see in lung cancer with poor outcome, and it looks like the video calling is a good way of having a follow-up to the patient. That doesn't mean that tomorrow we are going to replace it. No, we are going ahead with some more work, and then to see that can we find out a group of patients where we can avoid them coming from thousands of kilometers only to see us on the follow-up. How do we help the middle class? So we know that we do have a rich people who have a lot of money, so they can take anything you want. And you have a poor people, you do have the schemes from the government and many times from the NGOs and also from the companies where you get the BPL people free treatment. And this we realized while talking to the patients that they don't have those BPL card and suddenly they don't get anything. And we do know that lower middle classes has a huge problem in getting those money. They can sustain for some time, but not for a long time, and not especially for costly treatment. Again, with her persuasion, with the whole group of people, persuading all kind of people here and there, and we could convince at least 2 group of people that if they can fund us for these middle class people. And we try to generate the funding from CSR, and last year we could generate around 50 lakh for this. And this is primarily dedicated for middle class people, where they get this funding for treatment, where they can partly fund the treatment, and part treatment is given from them. I'm not sure this year we'll be able to raise the money considering the kind of pandemic we are in. We are very thankful for these people that they came forward and they understood the problem that middle class is not in our country such that they are able to take all the effective treatment. Now, how to help the Aam Aadmi patient during lockdown? All these features which we were doing during the time of non-lockdown, they did help us in doing many things during the lockdown, because we do run an email, which all our patients, they send the email to us during the non-lockdown period. And then we realized that the email, what we have started getting is almost tripled. So we had around 20, 25 emails every day. Then again, this initiative was from the NGO group, which suggested that as we have all the details of these patients, let us talk to them on Zoom. We were not sure how it will go. So now we do have almost many sessions, and what you can see, those sessions were there, apart from consultant talking to the patients, these are all those specific sessions where we had the specialist coming in and talking to the patients. What we found that yes, it was useful. It was a surprise for us that patients used to come on Zoom only to hear the consultant or the doctor saying them, if you are good, if you are taking tablet, there is no need to come to the hospital, don't come right now. And they were good enough to only hear this. So at this moment, we had almost 15 Zoom sessions. We started from April, and we had patients from all across the country, suggesting that there was a need, and there was a need from not only the urban area, there was also need from the rural area. Subsequently, now the hospital has started a teleconsultation, so you can go to the website of Tata Hospital. There's a formal teleconsultation which is there for our patient if they want. But we did start this interaction with our patient some time back. But realizing that a small interaction from the side of the clinician was good for them and they were happy about it. This was the same, showing that Zoom session which used to have every alternate Friday in the late afternoon. Subsequent to this, we do know that most of our Aam Aadmi, they are not able to buy the original molecules. They buy the generics. So some time back, we started a program. We started with pemetrexate to understand how good is our generics, which we do the drug level in the patient at our own lab, that is the pharmacology lab. So we partnered with our clinical pharmacology department, Dr. Vikram. And what we found, that I won't name the company here, that yes, we do have some very good generics in India. So we shouldn't be always be apologetic about it. And we have done this work in many other settings, and now administration has agreed to fund the whole program for all the generics which is coming here to see how they fare as compared to the original molecule. And that may give us more assurance to the Aam Aadmi that when they are receiving the generics, are they good enough or not? Now, how to implement palliative care in our patients? So we know that we want palliative care to be part of all the lung cancer patients, definitely stage 4 lung cancer patients. And we also want them as early as possible. We started to see the feasibility. This was in the collaboration with the palliative care department, and which we realized that as far the feasibility was concerned, this was 60% patient, 50% time of the scheduled coming to the OPD for the palliative care. And we found that yes, we couldn't. So 48% was percent time the patients came. So we just missed it, suggesting that there is an issue regarding feasibility of early palliative care in our setting. So we need to work hard to see that we improve it. But we are also doing a randomized trial, and that time in head and neck cancer, and it showed, as far as the quality of life is overall is concerned, in this randomized trial, the early palliative care intervention didn't improve the quality of life. Again, done in the collaboration of palliative care department. Do I mean to say that early palliative care doesn't work? No. What I'm saying is palliative care or early palliative care in our setting needs to be addressed in a way the problem our patient has. For example, I showed you the many problems in the past. All these individual problem is a part of early palliative care. I'll show you one other example. The distress management in, again, this is a head and neck cancer patient. I deal with this. So I am showing the example. What it showed, if you take those individual symptoms, which is the predominant symptom in the patient, then you are able to show that early palliative care helps. And in this situation, almost 80% of the patients, they had a decrease in distress when the distress was addressed. So when we do early palliative care and we want to evaluate all aspects of early palliative care in the quality of life, then many times the benefit which we give it, it doesn't get reflected in the quality of life parameter. So one is the measurement, and second is what we are addressing. That will depend upon the individual patient, what kind of symptoms we have. And if we don't address that, we may not have improvement in quality of life, suggesting that early palliative care, we need to have a different approach, and we need to do the specific symptom what the patient and the problem has to be addressed to have the impact of this early palliative care. I also mentioned about poor performance status patients. So we do have quite a few. We do understand, as I told you, almost 1/5 of our patients are like that. We did work on small cell lung cancer. This is our recent paper, 200 plus patients. And what we can see that if you are able to give chemotherapy, yeah, we did give chemotherapy in a different way. We give them baby step chemotherapy, initial a smaller dose, then kept increasing. And what we can see that if you do it, majority of the patient, you have improvement in the symptom, and you do have a looks like impact on the survival also. You don't cure these patients. Average life remains 6 to 8 months, but yes, this gives some decent quality of life to the patient in the short term. So this is one way to address the poor performance status patient in small cell. Have we done some work in non-small cell lung cancer? Yes, this is the two work which we did. And when we try to find out how do we go about it, so what we have been doing in the past, that all patients coming in the poor performance status, that means PS3 and 4, we didn't include PS2 patients in this group. Give TKI, if they improve, they come back. And by the time we get the report, and it appears because EGFR is the commonest mutation, and if you have those mutations, if you wait for the test, you may not be able to give this treatment, but you are able to give it, then those 25-30% of the patient, they do benefit, and the average life of these patients are around 12 months, again suggesting this is one approach which works. I know that there are many other approaches which people take it, will be happy to hear from other people. But usually PS3 and PS4 patient, no one wants to touch it, but somehow it is very common in our population, and we need to address this as we go forward. We are trying to do some other stuff in this setting, which we can share later on. Can we develop cost-effective treatment? We did try to, and this can be some of the examples and which one can take it forward at their own center. We tried to develop the low dose gemcitabine. So this dose was around 250 milligram per meter square. That was almost 1/4 or 1/5 of the regular dose. And what we show it here, that outcome was as good as what we can see with the regular dose. And what it does, it decreases the cost by 1/4 or 1/5, whatever dose you use in your clinic in this setting. So it allows that it can be used at multiple places, and especially when the patients are paying from their own pocket, or for that matter from government setup, you do save good amount of money. We also did a randomized trial to see comparing in the maintenance setting, pemetrexed to erlotinib. We do know that there is a study suggesting that erlotinib may be not so useful, but at least in our study in a randomized trial setting, what we see here, that progression-free survival and overall survival, they are absolutely at the top of each other. So either we interpret the pemetrexed doesn't work, but if we think the pemetrexed works in the maintenance setting, then it looks like, at least in our population, maybe erlotinib also works similarly. And in a patient who can't take pemetrexed, it is a good option, and it may turn out to be more patient-friendly option. If the patient can't come regularly to the clinic for injections, they don't want to get an injectable treatment, they don't want to go to daycare again and again, and maybe the follow-up maybe not every 3 weeks, it may be every 3 to 4 months if you are able to give this tablet, and again having a relatively cost-effective treatment for the patient in this setting. We also developed a treatment in EGFR mutation positive patient. We compare chemotherapy versus TKI, but then we try to take it forward to develop in this setting, can we improve it further? We combined gefitinib with chemotherapy, compared with gefitinib, and what we show that it not only increases the disease control, it also improves survival. This was well accepted. This was in ASCO News, ASCO Oval presentation. It was in top 30 abstracts last year. It was included in update guideline. It also is included in ESMO guideline. And we also had a commentary from Nature publication about it, and was also fairly well covered. But for me, most important is this slide. What we can see that we have 8 options in this setting. And if we take it that initial 3 options are relatively inferior option because of disease control and maybe also life improvement, then if we take those other 5 options, and what we see here, the treatment of TKI plus chemotherapy in our setting will cost you around 3 to 4,000 rupees per month, as compared to any other treatment which will be costing you 50,000 rupees per month, or 70 to 80,000 rupees per month, or 1.6 lakh rupees per month, with similar outcome. I'm not saying same because there is no direct comparison, but most likely similar outcome in this setting. This is feasible for all patients coming to our clinic. If they are from BPL category also, all state government, the amount of money, 1.5 lakh or 2 lakh, what they give per year, this treatment is good enough suggesting that almost any patient in this country, if you have a EGFR mutation positive patient, this treatment can be given with a similar outcome as compared to what we can achieve with 1.6 lakh rupees per month as far as the overall disease control and the survival is concerned. We did also develop the treatment for cough patients. We do know that lung cancer cough is a problem and we don't have much treatment after some time. And this is a randomized trial comparing aprepitant with other treatment, and it looks like it does improve cough in this setting. And I think so this is something which one can try. It is not as striking as we have seen in the previous drug, but it does help many patients. So I'll suggest that one can try in this setting when other treatments have failed. Did we develop some cost-effective investigations? Yes, this is the EGFR mutation testing, which we developed at the time when no kits were available in this country. And if you imported the kit, the per test cost used to be around 30,000 to 40,000. And we developed for a poor patient for around less than 1,000 rupees per patient. So we were able to give this test to every patient coming to our clinic at that time. We also did a work on mutation profiling, and this is Pratik here, who was a student. Now he's my colleague here in my department. And we did this mutation profiling compared with those Caucasian population. We see some differences, some newer one, but it also told us that mutation profiling, we comparing with lung cancer mutation consortium data, that yes, in a cost-effective manner, you can do research in our country, you can develop those mutation profiling, you can validate the outcome, and that may help us in developing the NGS, NGS test for the patient, again in a cost-effective manner. So we have gone ahead and we have developed a kit. We are trying to see that can we make it more cost-effective in this setting. And that happens because if you do those mutation profiling, then you can develop those panel relatively easily and with more information in this setting. We have almost 1/3 of our patients who doesn't wait for molecular testing before starting treatment because they are not in a good shape. They have a lot of symptoms. And that's the reason we were developing liquid biopsy. So we developed in our lab. Also, we collaborated with other people. And these are the two papers suggesting that concordance is around 80% and around 90%, suggesting that, yes, liquid biopsy test can be developed and given to our patients, especially in a situation where you don't have biopsy upfront for these patients. And same can be used in repeat biopsy setting. Some uncommon situation, remember, sometimes we do come across many uncommon situations in this setting where you have to persuade your colleagues to do something relatively uncommon treatment. And this is one of them which we did. Our orthopedic oncosurgeon, they usually don't entertain palliative patients. We have been kept pushing them for a long time that no, our patients are doing better now and we need to intervene. This is one of the patients where they had to do total femur replacement surgery in a TKI, EGFR mutation positive patient on TKI, and they did it. Now they are more receptive to it, and this patient had a good quality of life for years subsequent to this surgery. Again, something which we need to always think out of box when we are in the clinic to take help of our colleague to improve the outcome of these patients. All this is done only and only because there are lots of people around. This is a whole social worker group of people who works together with us. Everywhere we try to see what we have done and we try to see what we can improve upon, which we'll be doing again this year. This happens because primarily of this man, Mr. Sanjeev, he helped us collaborating in all these people to see that where we can raise some resources for our patients in some way or other, which helps our patients. These are all at the top, the students working in the lab, and below the coordinators and the student working in the clinic, which help us with all kind of work to see that these works move forward when we do in the clinic. These are my colleagues, the consultant, Dr. Amit Dutt from the lab, Dr. Vijay Patil, Dr. Amit Joshi, Dr. Vanita Narona, and Dr. Nandini Menon, who are from the clinic. And then you see Dr. Anuradha and Dr. Pratik from the lab. Again, absolutely gems, and it happens only because of them being together and every time being together. So these all data I present on their behalf, what you have heard today. Otherwise, it was not possible. So they own this as much as I have a contribution. They have contributed equally. This is the team from the Medical Oncology Molecular Lab for developing those tests and doing those tests and doing those work and collaboration to see that it happens. These are the bosses which are very important. Unless they are supportive, it doesn't work. And my teacher, Dr. Bapsi Madam, Dr. Banavli, my ex-HOD, and now again my boss, and Dr. Badwe sir, I'm sure everyone knows. Always willing to help with any issue you go to, and that's the reason these work happens. These are all acknowledgement for the people whom I work with, and this is my family, and thank you so much. I'll be happy to take any questions.
Thank you, sir. Thank you so much. I am so happy that we managed to get this lecture, and I'm so thankful to Nitesh that he spoke with you and we titled this lecture, because, you know, it's very important to bring out what cost-effective measures we have suggested and you have actually implemented. Now, believe me, sir, if this was a hall today and you were speaking in a hall today, I would really have 50 people standing and, you know, wanting to speak to you or wanting to ask you so many questions. Unfortunately, we don't have that, but we still have Dr. Rakesh Chopra sir with us. I would want him to come in to just present his views on this. That, sir, how do you feel we have moved on, and how you feel these measures can actually help us improve the lung cancer patients? Dr. Rakesh Chopra sir, please.
It says unable to start the video because the host has stopped it. Sir, can somebody look into this, please?
Yes, sir. Just restart it, sir. You will be able to do it, sir. Yes, perfect, sir. We can see you well. We can hear you well, sir.
All right. Thank you so much. And I'm so happy that the Mr. Lung of India, of Mr. Lung Cancer of India, Prabhash, has given us a beautiful overview of what can be done for a large proportion of patients in this country. Now, he has really outlined beautifully what is possible for major populations of this country to whom healthcare doesn't reach. So there's a lot of possibility. Now, I would like to take 5 minutes to take you through the journey of lung cancer that we have in our time seen. Now, we started in the late 70s, early 80s, when for advanced lung cancer, it was best supportive care. It was best supportive care. And the survival in those patients was less than 2 months. And from there, it moved on to chemotherapy, and there was single agents, there was platinum came in, and the survivals improved. It was single agent, double agent, triple agent, quadruple agent, back to doublet. They found that triplet and quadruplets were no use. Then there was a time when gemcitabine came into this country through Lilly. And I still remember going to the minister at that time and requesting him to reduce the taxes on gemcitabine so that more patients could get the drug for advanced lung cancer. So that was the time when the sales of Eli Lilly went up hugely, because a lot more patients could get gemcitabine at a relatively cost-effective rate. Then we saw, prior to that, we saw cisplatin come in. And I still remember when we started using cisplatin, we have stayed up all night trying to watch the urine output of patients because we weren't sure whether we'd go into nephrotoxicity or not. Now it's a child's play, but at that time it wasn't. And then carboplatin came into this country, and then pemetrexate came into this country. Also, as I keep talking in many interesting forums, and I'll say it again, the classical example of innovation comes when the IPASS trial was done by the now legendary Tony Mock. And I keep telling people, I said, we were all at a meeting of Eli Lilly in south of Borneo, in Kota Kinabalu, and there over a dinner meeting, and I had reviewed at that time the adenocarcinomas where there was a certain subset of patients who used to do very well. And I talked to Tony and I said, look, why don't we do something And that's when, although the trial for Jeftinib in US was negative, he went and studied this in a certain subset population and proved, and what is today the standard IPAS study, which has come to stay in all our armamentariums. From there to erlotinib, to other drugs, and then to the resistant forms, and so on and so forth. So what I'm trying to say is that lung cancer has made a huge progress. And I must compliment Dr. Prabhash again for their innovative work in availability of diagnostics at 1,000 rupees. Now, if we can do this, then in the present COVID situation, the ICMR has stepped in and allowed a lot of laboratories to do these testings at cheaper rates. Then why can't anti-cancer molecular diagnostic features be taken up on that footing so that more and more patients can get better, more specific therapies in this group of patients? So I think that's an area, Prabhash, that you need to lead so that people can get more and more diagnostic criteria and be able to afford these, especially at the, not only at the urban area, but at the rural areas also. The third thing is
very well summarized, Dr. Chopra. Yeah, perfect. Harit Chaturvedi here.
Harit Chaturvedi, is it too late for you to go home? Can I
No,
take
no, we are all at home only.
So it'll just give me another 2 minutes because I seldom get a platform to speak. I'm an old man. I'm semi-retired. So if you don't want me to speak, I'll bugger off from here. But if you want me to continue, I'll just take another 2 minutes. Thank you so much. And the other thing is about the drugs. Yes, we have better methods of using these drugs. And as Prabhash said, you can use, this thing about maintenance therapy. I've had patients who've lived 15 years with maintenance therapy with methotrexate, those who didn't have any mutations. So there, and then the low dose Jeftinib, and so on and so forth. You have a lot of innovations, and that should be the challenge for our younger group of doctors in this country. I thank you so much for this platform. I thank Prabhash, and I thank Harit and all the organizers for having me to speak at this forum. Thank you very much.
Thank you.
Thank you, sir. Thank you.
Good night
Thank
and
you.
have a good evening.
Yes, thank you, sir. Thank you so much. I think what promise I've made to myself that I have 1 week before the actual medical oncology starts. So today was the end of the surgery and the radiation, as we say it. It's not the end, but actually a broad line that we draw, which never gets to merge. It stays that broad. And, I will go through Dr. Prabhash's talk again, and I will sit down with my medical oncologist, that is Nitesh, and Sajjan, and Dr. Minuwalia, and Dr. Gopal, and we'll try to find out what I can change in my system, because what Dr. Prabhash says, my 80% of lung patients that I register in my thoracic DMG are metastatic to begin with. And we have to find out what changes we can bring in within ourselves. And I really learned a new term today, which is ground shot, sir. It is so very important. Ground shot, why are we aiming at the moon when we are not, standing firm on a ground? So we have to find our ground shot. And I don't know if ISS LC is the right platform, and we as physicians involved in lung care can take that lead and define 2 ground shots, probably in this conference, sit down with Dr. Behra, with Dr. Navneet, and find out those 2 things that we will probably start and do it till the next NALCICON. I think I would have achieved the aim of this conference. So thank you.
I think the secret is collaborative work, and you need to get collaboration amongst colleagues, amongst centers. Maybe all the centers in Delhi NCR can collaborate, whatever it is, but come up with good, nice solutions.
Thank you, sir. Thank you so much. And what Dr. Chopra also spoke about, Tony Mock. Tony Mock is going to be with us next weekend to talk about not IPAS, but how he looks EGFR is going to be in the next 5 years. And I assure you, it will be as revolutionizing talk as Dr. Kumar's has been. So thank you so much. Thank you, everybody. Good night. And today we end the day 2 of NALSICON, and we look forward to meeting all of you again next weekend, 4 o'clock, Saturday, 3rd of October. Thank you so much. Good night, everybody.
Thank you.
Dr.
Thank you,
Kumar.
everyone.
Thank you.
Thank you.